A very good morning to all of you, our distinguished guest of today, our very own dearest Lord Jiteshbhai Gadhia, my President of Lohana Community North London, Shri Thakrar, the various dignitaries and speakers that you will soon hear, various past presidents of Lohana Community North London, my fellow medical camp committee members and executive committee members, a very good morning to you. And welcome to this second year of the presentation of the medical camp. Doctors have a job. They have a job to research what your problem is. They will carry out a diagnostics. And after doing that for 6, 12 months, whatever it takes, they will begin to have faith that this is your illness, and they'll then treat you for the illness in the right way. With God, it works the other way. You have to have faith first. It's only with faith that you can move forward with it. And the reason I mention this is that today, the two professions, I suppose, which you can comfortably call, because the doctors are going to do something magical today or miraculous today as well, or anytime in the future, have merged today. And the reason for this is simply a saying that I think I've said many times, that Manav Seva is Madhav Seva. To serve a human being is to serve God. If you see anybody that you treat, see that person as a reflection of yourself. Needless to say that when the doctors are undertaking some of their duties, they would have difficulties. It reminds me of an incident when a father-in-law needed some serious treatment, fairly serious. And all the surgeons were ready to treat him. But the father-in-law said, hang on, I've got my son-in-law who is the expert in this particular illness. So I only want him, my son-in-law, to perform this operation on me. The son-in-law turned up and he spoke with his father-in-law, very nervous. The father-in-law said, look son, don't worry and don't be nervous. Treat me without a difficulty. But just remember one thing. Just remember one thing. That is, if anything happens to me, your mother-in-law is going to come and stay with you. And you can see after that, there was no question. It was perfect. So really that takes me to the same subject, is that whilst undertaking this task of organizing and executing the medical camp activities, I had some wonderful people, and I've had some wonderful people working with me. Particularly I've had some, as you know, I call them the angels who work with me, and the ladies always doing a fantastic job. And I simply say to them that, look, if anything doesn't go right with this medical camp, I'll just tell them, you are the responsible one. So I think they've done a wonderful job. I think the two ladies, of course my executive committee consists of all the people who are named, but really thanks very much to my secretary, Sukeshi, and of course my volunteers coordinator, Malini, wherever they are, they're probably listening to this. I think that is a nice round of applause. I'm also very blessed that I've got a number of doctors on my team, and I'm very blessed to have, I think, Dr. Bhik, Kotecha, who assisted Jatania to source our speakers. So very grateful to them. We had the young GP, Ami, who has sourced a lot of the GPs for us. Most importantly, you will see that there's a clinic upstairs for the pharmacists, which is not only run by Jade's Pharmacy, but also this event has been partly sponsored by Jade Pharmacy, so very, 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 very grateful to them. Thank you very much. I think they do deserve a lovely round of applause. At the far end of the hallway upstairs, the clinics are run by the Sai organization, which has associated with us last year, and equally they've done it this year. The best thing with the Sai organization is, of course, simply as a Swaminarayan organization. Planning, execution. They bring their volunteers, they do the job, they do the seva, and they go. So we're very grateful to them. Not forgetting our social team, which has also helped us, Vishal Bhai, Sushma, and all your social. We are very, very grateful to you. And finally, on the quick list of thanks, all my operating committee organizations, which are of course the senior ladies and men, the Mahilas, and most particularly the wireless, which is doing a wonderful job through their current president, Ami Samani, who is going to make some introductions and talk as well. I won't talk too much now, but I'm pretty sure that as per my Lohana tradition, I will probably forget somebody or someone along the line. So I'll come and say a thank you or whatever needs to be said then. But what I would now like to do is I'd like to, without taking much of any further time, I'd like to introduce the speakers so we can get on with the event of hosting the seminar. And I'm going to invite our Assistant Secretary, Sanjay Rajani, to come and introduce the next speaker. Thank you very much.
My Lord, respected elders, ladies and gentlemen, wonderful to see you all here today at this medical camp. And as Jiteshbhai said, a lot of time has gone into this event, second year running, and might I add, last year's success will be this year's success, if not better, and hopefully we'll continue with this. By Thakrar, pulled this to the fore. My role today is really to introduce Chandni Rajani, a hypertension specialist. I think we all need that silent killer reduction in our lives, I'm afraid. But just to give a bit of background on it, Dr. Chandni Rajani specialises in general practice in London, and her background is in anaesthesia and intensive care medicine. She graduated from King's College London in 2012 with a distinction and a first-class honours degree in BSc Physiology, King's College London, for which she was awarded the prize of coming top of the year group. I think that deserves a round of applause itself. If I may continue on that, Chandni has undertaken research projects, audits and quality improvements projects which have been published in journals and has also been asked to present these internationally. So we're very privileged today, so thank you for being here today at the Lohana Community North London and sharing all your research with us in that regard. These included Chile, Italy, Oslo. One such project involved climbing the peak of Mount Kilimanjaro, which is on my list of things to do, so I'd like to actually talk to you with my brother Bharat here, who keeps promising me to do that. So watch that space. Studying psychology and the effects of this climb on herself and her peers. This was an insightful and rewarding experience, and I do hope you will share that with us. So without further ado, may I introduce Dr. Chandni Rajani.
So good morning everyone, and Jai Shri Krishna. It's a real honour to be here today, to be speaking to the Lohana community on a very important and a very common topic, and that is hypertension, otherwise known as high blood pressure. Can everyone hear me at the back? Yes. Perfect, great. So I want today's talk to be interactive. I'd like you to feel like you benefit as much as possible from today's talk. So if there are any questions, or if you'd like me to repeat anything or slow down the pace, please do feel free to let me know and we can do so. Perfect, so let's start off with what we actually want to cover today and today's objectives. I thought I'd start off by talking about hypertension or high blood pressure. What does that actually mean? Why is it even important to us? Why is it important for us to know what it means? Secondly, what are the dangerous effects of having a high blood pressure? What does that put us at risk of developing? Thirdly, I thought we'd move on to the incidence, or how common is having a high blood pressure. Next, move on to the diagnosis. How do we actually know if we have a high blood pressure? Then I thought we'd talk about the causes and what actually predisposes us, the risk factors of having a high blood pressure or hypertension. And finally, and I'd say probably the most important part of this talk, is preventing and managing high blood pressure, because this is the part of the talk that we can actually actively engage in and do something about, okay? So that's the real focal point of my talk. So high blood pressure, what exactly does that mean? We all have a heart that sits in the left-hand side of our chest, and the job of the heart is to pump blood around to all the vital organs that are distributed throughout our body. Blood contains oxygen and nutrients, and it flows through blood vessels, which are basically big tubes. Blood pressure is the strength at which the blood pushes against these tubes. So having high blood pressure means that your blood is really pushing hard against the vessels as it pushes down from the heart to your organs. And that puts strain on your blood vessels, and it puts strain on your heart. And that strain on your heart is what causes heart attacks, strokes, and heart failure. Okay, so it's really an important thing to understand and appreciate. Is everyone with me on that?
Yes.
Great. So a lot of people probably have had their blood pressure checked upstairs or at your GP surgeries, at your pharmacies, and they usually tell you two numbers. They usually say to you, it's something over something, and the cutoff for high blood pressure is roughly 140 over 90. So if your blood pressure is under 140 over 90, we say on general that's okay, and we'll actually talk about diagnosis in a bit more detail later. Those two numbers, the top number is the systolic blood pressure. Don't worry too much about remembering these names, it's just to put a little bit of context to what you may hear. And the systolic blood pressure, or 140 in this case, is the blood pressure when your heart contracts. The diastolic number, or the number on the bottom, in this example 90, is the blood pressure when the heart relaxes. Okay, so that's what those two numbers mean. What are the symptoms of having high blood pressure? Well, unfortunately, there are barely any. There are no symptoms for having high blood pressure. So we could be walking around with a high blood pressure with no idea that we're suffering from this. And that's why on my first slide I referred to it as a silent killer, because we simply don't know we have it. And that's why it's so important to monitor and keep an eye on your blood pressure. Okay? If it's very high, sometimes people experience headaches or visual disturbances, but like I said, usually most people experience no symptoms at all, and that's why monitoring is of utmost importance. So why do we care so much about having high blood pressure? What are the actual consequences? What things can actually happen as a result of this condition? We've spoken about the stress that pressure puts on your heart. Subsequently, we can develop heart attacks, we can go into heart failure. It also has complications with the brain, so one may develop a stroke if they've got an extremely high blood pressure. It can interfere with the blood vessels that actually supply the brain and cause something called vascular dementia, which is actually a general decline in your brain's ability to function. So as you can imagine, that's a very, very severe and unfortunately very common presentation that people develop after high blood pressure. It can cause retinopathy, which means eye disease, so interfering with the blood vessels at the back of your eye, and that can even lead to blindness in severe cases. And similarly, it can disrupt the blood flow to your kidneys, causing kidney disease, which can actually develop into kidney failure. And finally, peripheral vascular disease, which is interruption to the blood flow supplying your hands and feet, and that can lead to ulceration and various problems with your circulation. So as you can see, there's really a myriad of things that can be a direct effect of a high blood pressure, and that's why it's so important to actually try and combat this. And this slide here just reiterates what I've spoken about, which is the complications. The eye, the heart, the kidneys, and also the brain, they're all at risk, and we know without all these things, our quality of life or even our life just wouldn't exist, and that's why it's really, really important to pay particular attention to your risk factors, for example, having a high blood pressure. So what is the incidence? How common is having high blood pressure? I just want to put this out to the audience, okay? So put your hands up if you think 1 in 100 people in the UK have a high blood pressure. 1 in 100, so that's 1%. So there's a few people, okay? What about 1 in 50? A little bit more common. Okay, so there's a fair few of you here that think there's 1 in 50, fine. 1 in 25? Okay. 1 in 4? Good, because it is 1 in 4. And that's shockingly high. So that means, I mean, you can see 4 people in the audience sitting next to you. 1 out of 4 will probably suffer from a high blood pressure. They're either aware of that or they're not. Okay, so the point I'm trying to make is that this is hugely common. And in our population, unfortunately, it's probably close to 50% of anyone over the age of 60. Okay, so it's particularly important for us. So it's far too common and it's becoming more common. And I've said 1 in 4 people in the UK, so not just the Indian population, but the Caucasian population also. Over 5 million people are actually unaware that they have a high blood pressure, so they're walking along the streets without any symptoms, completely unaware. It's the biggest risk factor for an early death. And the WHO, which is the World Health Organization, actually estimates that it causes 7.5 million deaths annually and nearly 13% of all total of all deaths. So really huge implications here. The National Health Service itself spends over £2 billion a year on high blood pressure related causes of illness. So it's a huge budget, it's a huge number, and it's something that we as a population need to work on. It's not just the UK, it's a worldwide problem, and this graph is actually from 2012, so it's a little bit old, and I predict problems probably got worse since then. But this looks at the Americans, and 67 million people in America actually have a high blood pressure, of which 53 million people are aware, 47 million people are treated, and only 31 million people actually have control of their blood pressure. So that's less than half of that population initially. So there's a huge under-treatment and under-control of hypertension. And that's really one of the key points to take home with you today. So why us? Why the Indian population? Why the Gujarati population? You know, why is it us that are predisposed to this? And I've given you a few clues here. The genes, fine. It's in our genetic makeup. Unfortunately, there's not a huge amount we can do about that, guys. But the diet and the lifestyle are huge, huge factors that play a big role in actually contributing to this higher incidence in our population. And those 2 things are something we can actually do something about. And I'm going to be talking about that in a bit more detail later on in my talk. So it's an interplay between these 3 factors that actually predispose us to cardiovascular ill health in general. So how do we know if we have a blood pressure, if we have a high blood pressure? It's not a snapshot diagnosis. That means I can't take you upstairs now, measure your blood pressure, see that it's 150 over 90 and send you home with some pills and say you've got a high blood pressure. It doesn't work like that, okay? Your blood pressure will rise and fall during the day depending on what you're doing. Some people find just coming to the doctor puts it up. That's called white coat hypertension. And actually, I'm sure a lot of people in the audience do suffer from that. Similarly, if you're exercising, if you're stressed, your blood pressure will be a bit higher. If you're relaxing, sleeping, meditating, your blood pressure will be lower. So the way that we diagnose hypertension is actually by doing an average reading of what your blood pressure is during different points in the day. And usually your GP will give you a blood pressure cuff, ask you to record your blood pressure over a 2-week period roughly at about 10 different points in the day. They'll have a look at your readings and then they'll decide what your average reading is. Or they may send you home with something called an ambulatory monitor, which is something you just keep attached to you and it measures your 24-hour blood pressure, okay? So it's not something you can diagnose on the spot. So the key here is to just monitor, keep monitoring. Even if you don't think you have a high blood pressure, there's no harm in getting it checked every other week or so at your pharmacy, your local GP, by your local nurse, okay? Especially if you're over the age of 45 and you've got risk factors. And we all know, I think everyone in this room has a risk factor, our genetics. So we've talked a little bit about causes and risk factors already. Can anyone name any risk factors apart from the one that I've just told you, which is our race? Is there anything? Has anyone got any other ideas of what could predispose you to having high blood pressure?
Anxiety?
Yes, absolutely.
Stress.
Yeah, stress and anxiety, definitely. Anyone
High
else?
salt diet. High salt diet.
High salt diet. I'm really glad you said that because that's a huge, huge problem, and that's a huge contributing factor. So absolutely a high salt diet.
Obesity.
Diabetes, I heard, yes, that is a causing factor. Thank you.
Obesity.
Obesity, huge, absolutely. That is a real contributing factor. So I'm really glad that we all do know some, and I've put up a little list here. to make things a little bit easier to go through. But essentially, being older than 65 automatically puts you at risk. Having a family history of high blood pressure, so any of your first degree relatives, your mum, dad, suffering from a high blood pressure puts you at risk. Being overweight, which we've heard, so a body mass index of over 25, that clarifies that sort of constitutes obesity, and that puts you at a high risk. Drinking alcohol in excess puts you at a high risk of developing a high blood pressure. Smoking is a huge contributing factor. Diet and salt intake, which you kindly volunteered there. The lack of exercise, lack of sleep, and they say less than 6 hours of sleep per night actually puts you at a high risk. Stress, and then others that we heard over here, so diabetes, kidney disease, sleep apnea, which I'm sure we'll hear a little bit more about, and endocrine problems, so those are things like thyroid problems. So there are lots of risk factors. Does anyone know why I've underlined some of these? So you said they're probably more related to our culture. So that might be true, but that wasn't necessarily the reason that I've underlined them. The reason I underlined them was because these are risk factors that are modifiable. Okay, that means we can actually do something about these risk factors. Being over 65, unfortunately, you can't do much about. And again, our genetics we can't do much about. But everything else we can actually combat. Okay, and that's active engagement in actually preventing these things from happening. So we've spoken about this, the environmental factors and our genetics together interplay in order to cause a high blood pressure, okay? So this is the bit where I think everyone will really benefit most from listening to, and I think this is the part that I really want you to remember and take home today, because it's something we can actually do something about and actively engage in. So my first thing to point out is prevention is better than cure. It's better to prevent yourself from developing a condition than from developing it and then having to cure it. Okay, and I think everyone would agree that is a better strategy. How do we prevent it? So things that we already know and things that we've already touched on: having a healthy diet, not smoking, reducing your alcohol consumption, sleeping well, reducing stress. Exercise. So exercise is an interesting one because it means something different to everyone. So some people regard exercise as going for a brisk walk, some people regard it as running a marathon. So it really depends on what your level of fitness is, but we recommend at least 3 to 5 weeks you should be exercising for 30 minutes, and exercise means you should be feeling tired, you should be feeling pushed, you should be sweating and your heart should be racing. Okay, so it's often more than a walk for most people. Obviously, if you develop any chest pain or dizziness, you should stop immediately and seek medical attention. But generally, the way to exercise is to really push yourself. So something that I think would be important for us to focus on today is a healthy diet. And the healthy diet, I suppose, is a well-balanced, low-salt diet that involves lots of fruit and vegetable, at least 5 fruit and veg a day. Fruit, just as an aside, is actually quite high in natural sugars. So that doesn't mean you need to avoid fruit, but just be mindful of that, especially if you have diabetes, because it can contribute towards your blood sugar becoming elevated. So I've put up some lovely food that I'm sure everyone enjoys, and I haven't put this up just to make everyone hungry for lunch. There is actually a reason that I put this up. So what do all these foods have in common? Sugar, salt, absolutely. These have this group of food has a huge amount of salt in it. Okay.
So you can say the trans fat.
The trans fats, absolutely, very, very true. So these are all fried. They're all salty. They've got things in them that we shouldn't necessarily be having on a daily basis, but salt in particular, because we probably don't realise how much salt is actually in these foods. On average, per day, you should be having 1 teaspoon of salt. And salt is hidden in bread, in cereal, in sauces, in salad dressings. And after that, we start adding salt to our food. So actually, we've probably more than doubled our intake by the end of the day. And actually, salt is probably one of the major risk factors for developing high blood pressure. So when you first cut out salt from your diet, you tend to think, oh, my food doesn't really taste very tasty anymore, and how can I cook without salt? But actually people manage to do it, and people manage to use things like lemon juice instead, or use herbs or spices to actually make food taste slightly more flavoursome. So cutting out salt, I agree, is a difficult thing to do, but reducing your intake of salt is something that we should all actively be trying to do. And the max salt allowance is 6 grams, which is really not very much, it's 1 teaspoon. And remember, there's hidden salt in everything we eat. So have a look at the back of your packet next time you buy a ready meal or buy some crisps, and you'll notice that there is a fair amount in there. So the NHS Choices have actually developed something called the Eat Well plate. And this is meant to give you rough guidance as to what you should be eating, what proportions you should be eating them in. 2/3 of your plate should really be fruit and vegetables, and we've spoken about the sugar content of fruit. 1/3 of your plate should be fruit and veg. 1/3 should be starches, okay? And by starches, we want things that are low glycemic index. That means that they release sugars into your bloodstream slowly and steadily throughout the day, so that you remain full for longer, and it stops your blood sugar from spiking and going up and down. So we try to actually involve things such as brown bread, brown rice, brown chapati flour, instead of going for white rice and white flours, which are less beneficial in that respect. 1/6 of our plate should be milk and dairy foods, and milk, the fat content in full fat milk is actually considerably higher than that in semi-skim milk, but you still have the same nutritional value from semi-skim milk, the same calcium content. So for those of you who have full fat milk regularly, that might be something that you consider switching as part of your sort of taking a more healthy stance on your diet. Again, 1/6 should be non-dairy sources of protein. So for us, that's lentils, that's chickpeas, pulses, and soya, and things like that that actually give us protein in our diet. And then only 1/8 should be fat and or sugar. And remember, a lot of what we eat already contains fat and sugar. So adding sugar to things is actually adding on top of what you've already consumed in the day. Okay? So I'm not trying to scare everyone, but there is a lot of hidden sugar and salt in everything we eat anyway, so it's important to actually be aware of that. On top of that, we should be having at least 6 to 8 glasses of water per day, and they say that when you're hungry, 70% of the time it's your brain mismanaging signals, and it's actually your brain, you're actually thirsty, but your brain doesn't identify that, your brain thinks you're hungry. So often drinking water prior to having a snack will fill you up anyway. Okay, so that signalling in your brain isn't as accurate between hunger and thirst. Treatment is something that I really briefly want to touch on, because prevention is better than cure, which we've learned today, and I think this is very specific for per individuals, and it's something that could be a talk in itself, so I'm not going to bore you too much on any pharmacology. But the medication type depends on your age and your ethnicity, and your doctor will decide what is best for you with respect to treatment. And they generally take a stepwise approach to this, and the National Institute of Health and Clinical Excellence have come up with some guidelines. Again, don't worry too much about this. Essentially, all there is to take away from here is that they start you on one treatment. If that doesn't work, they'll add in another drug. And if that doesn't work, they'll add in another drug, okay? And that all depends on your age of presentation and your ethnicity. So it's a stepwise approach in management, and of course you'll be doing all your healthy eating and your lifestyle factors alongside this. So some take-home messages for today, what I actually want you to really remember from this talk, because I know it's obviously a lot of information to remember. There are no symptoms with high blood pressure. It's a silent killer, and that's why we need to be on top of it, and that's why we need to be aware of it. Secondly, it's not a snapshot diagnosis. So that means you cannot measure your blood pressure on one occasion and be certain that you have high blood pressure or you don't have high blood pressure. Thirdly, we should be aiming for a blood pressure of less than 140/90 in general. However, diabetics should be aiming for less than 130/80, because they're actually at a higher risk of developing heart attacks and strokes anyway, so they need a tighter control of this. It causes a great increase in the risk of heart attacks, strokes, heart failure, kidney disease and eye disease, and prevention is certainly better than cure. So I will leave you with this: eat well, exercise more, be happier and live longer. Thank you very much.
Thank you, Dr. Rajani. We've got time for a couple of quick questions, so if anyone's got a question, we've got one.
Thank you very much for an excellent talk. Can I ask you two questions? One is, if you could tell us, you said 1 in 4 of the general population suffer strong high blood pressure. What's the figure for the Indian community? That's one. And let me finish and then you can come back. My other question is probably more something I've been thinking about. If you take people of my generation and then you take people of my children's generation, I mean, they've been born here and they're probably subject to more information and education and so on. Is there any evidence that the level of high blood pressure within the Indian community is changing? Because some people are saying, just time will sort this out. Yes, you don't need to do anything. Just continue the messages and so on, and time will sort that out. I'm not sure that's the case, but is there any evidence for that?
Thank you. Those are both very interesting questions. So to answer your first question first, what is the incidence in the UK's Asian population or in the Indian population? And I did try and find a figure for that, but it isn't actually documented anywhere. Okay, but it's a real shame. But I know for a fact that it's higher. Okay, all they state is that it's higher, but they haven't actually given us any values for that. So that's something certainly that really should be looked into. To answer your second question, so are the younger generations perhaps becoming more shielded from such a diagnosis? I think that is interesting. I think that in general the population is ageing. That means that it's sort of getting older anyway. And therefore diagnoses of everything are increasing. Our ability to diagnose is probably going up. And lifestyle in general is becoming more sedentary, and even though people understand the importance of exercise, the UK's population is becoming more obese, and therefore they are more predisposed to having high blood pressure. Some people will combat that with exercise, but others, and unfortunately most people don't.
Great. We have another question here for you.
Right. First of all, a very good morning, Dr. Rajani. Thank you very much for the in-depth conversation regarding this about the heart disease. My only question is that sometimes when I'm sitting, relaxing and watching TV, after having my meal, I get this heartburn. Now I'm a bit worried about this heartburn. What it causes the heartburn? I know it is not it's not something which we have to worry too much about it, because the heartburn comes and goes. But is there any sign which indicates that there's something wrong with your metabolism, or what do you call it?
Heartburn, I suppose, is more related to reflux. Okay, so eating spicy foods, eating big meals, eating greasy food can predispose you to heartburn. However, being able to be sure that you have heartburn as opposed to chest pain, that's more worrying. Okay, so if you find while you're exercising you get any symptoms, or while you are stressed you get symptoms, then that's something that is certainly worth sort of investigating. But heartburn in general is usually fairly benign, and it usually comes on after heavy meals and sort of the type of food you're eating as well. But if you are worried, then you can always get an ECG and have a checkup with your general practitioner. Does that answer your question?
Thank you very much. Sorry.
Sorry, we might have to do one last question. The consultants will be around afterwards upstairs for you to ask further questions, or I'm sure after the talks. Okay, thank you.
Thank you. Hi gentlemen, thank you again for an excellent talk. My question is that the method by which blood pressure is measured, does that have a bearing on the results? Because it seems to me that the traditional way of measuring blood pressure, which is sphygmomanometer, whatever his name was, just said, I think that technology is 70, 80, 90 years old, and it's still the gold standard from what I gather in determining and then diagnosing blood pressure. So do you think with the technology we have now, that is now old technology on which a lot of the diagnosis these days is made?
That's a very interesting question. So yes, that technique has been around for years, and certainly we know evidence has shown that if you're using the wrong size cuff, so if you're using a cuff that's too small for you, you're going to be over-reading your blood pressure readings. Similarly, if you're using a cuff that's too large, you're going to be under-reading your readings. The newer digital blood pressure machines actually don't work in the same way. They don't work in the manual method. They actually work via something called oscillometry, which is we can speak about after the talk. But I think that they have been validated. There has been a lot of research and a lot of validation, and there are more invasive ways of measuring blood pressures. Okay, that would involve putting a line into your radial artery, which is an artery that sits in your wrist. But I can probably speak on behalf of most people that we probably wouldn't want that in measuring our blood pressure. So I agree, it is sort of having to rely on equipment, but it is very well tested equipment. So as long as your cuff size is okay, in general, your readings are fairly accurate. And those have actually been measured against standard invasive monitoring techniques.
Thank you, Dr. Rajani. I think that sort of covers all our questions. Can I have a round of applause for Dr. Rajani? So, Keshaben will introduce our next speaker.
Hello everyone, I'm back again. I'm going to introduce you to Dr. Kakad, who is originally from Mbale, Uganda. He qualified from Bombay University in 1974 and came to UK in 1974. He has been a general practitioner in Romford, Essex since 1974. He has developed special interest in rheumatology, dermatology and cardiology. He practiced at Queen's Hospital in all above specialities till his retirement in 2016. He has been awarded a prize for excellence and achievement in general practice, in addition to an award for long clinical service from Havering NHS Trust. He pioneered specialist community service in rheumatology, ENT, orthopedics, gynecology and neurology. All present, he runs state-of-the-art private clinic in Hornchurch, which caters for all clinical specialists. So would you like to welcome Dr. Kakad, please?
Thank you for that introduction. I hope I can live up to your expectations today. Thank you for the organising committee to invite me to speak to such a large audience. And as you have noticed, the topic given to me is arthritis, because I'm the only one who's over 40 here. Okay, I think the way to deal with this topic is a huge topic, and I will briefly touch on the salient points that you should be aware of, and then I will leave it to question and answers. The other thing I would like to say is, as you get older and you get to my age, you've got fewer and fewer slides. So you'll be pleased to know that I've only got 8 slides for you. One of them is my name. I think the other bit that I would like to say is, I think the previous speakers had lots of writing done, and as you get older and you get arthritis in your fingers, you write less and less and less. So my slides have got very few writings. Easy to read, okay? Okay, so let's talk about arthritis and how big a problem that is. And I think to give you a rough idea, anybody who is above 40 here has arthritis. But you do not all have symptoms, and that is the good part of it. The other good thing about it is, as the previous speaker said, arthritis does not kill. Blood pressure will kill eventually. So it doesn't. So you are in safe hands, safe grounds. I think the other bit that we need to realise that about 13% of population of UK consult their GP, which is the first port of contact in this country for some sort of joint pains. So it is a huge problem. And the main problem, people come to us as general practitioners, or hospital doctors for that matter, is difficulty walking, bending, which is the biggest problem, and then walking. These are the first symptoms that people develop with arthritis. Don't forget, it is not the disease of only people over 40. about 300,000 children suffer from arthritis in the UK only. It is a huge problem, and it's a problem even in a very young age. So don't be under the impression that you are 40 plus or you're under 40, you do not have arthritis. You do. Especially people who had accidents and traumas and do certain occupations, they do develop arthritis at a very young age. So it is a huge problem. I think the other thing that we need to realize, I mean, I'm unfortunate enough to work for the Department of Works and Pensions, and I sit on tribunal cases where I have to award tribunal for people who are off work for their backache. And England today pays close to £5 billion a year in benefits to people who are backache. So it is a huge, huge, huge drain. This is only money. Forget about your home life, forget about your daily living. So I'm going to briefly tell you what sort of arthritis we deal with. I think there are about 25, 30 types of arthritis, and I'm only going to deal with 2 or 3 today, and then we will leave the rest for your question and answer session. And one of the most commonest arthritis, which I said earlier on, is osteoarthritis. And this is an arthritis which basically begins with deterioration in your ligaments in your joints, and your joints gradually start to loosen. And then your muscles around your joints have to work harder to make you walk, make you bend. Consequently, they get swollen, they get painful, and they get out of shape. And that's where you get into problems. So that is the commonest type of arthritis. And the main problem here is the cushion, the ligament, and what holds the 2 joints together. That gets weakened, and that's where you've got a problem. The next type of arthritis, which is very common, and again there are about 400,000 people suffering from this arthritis in the UK alone, is what we call rheumatoid arthritis. Now this is an arthritis which is an autoimmune disease. So in other words, your own body cells are fighting against your joints, and consequently you get arthritis. And pathology here, or the main culprit here, is the capsule around your joints, which gets inflamed. And it secretes toxic substances into your joints, and then it destroys your joints. So it is an entirely different type of arthritis. It requires an entirely different type of management. So do not be fooled by arthritis. It is not one entity. The other distinguishing features is that osteoarthritis is an arthritis that comes in weight-bearing joints, so in your spines, in your hips, in your knees. Rheumatoid arthritis, on the other hand, is a small joint disease. It comes in your fingers and toes first. Other joints come later on. But because it is an autoimmune disease, you get problems with other organs in your body as well. So it is quite a serious condition to have osteoarthritis compared to, rheumatoid arthritis compared to osteoarthritis. The final arthritis that I want to briefly touch on is gout. And fortunately for me, all Luanas are well-to-do guys, yeah? So this is the disease of well and wealthy. Yeah? You have lots of wines and beer and you get so. That's a myth, that's not true actually. This is an arthritis because your body produces a lot of acids in your joints. And then it destroys your joint. So, and it mainly affects the big toe joints, but it can come anywhere. But the unique thing about this is it can be one joint, it can be many joints. So it's a disease which you really need to think about. But again, the treatment here is quite different because here you're dealing with an acid called uric acid, which you need to suppress to get your arthritis under control. You probably will not need any painkillers to treat this arthritis. So again, it is very important that we deal with these sorts of diagnosis in the first place before we do anything at all. I'll briefly mention that lupus, and again this is an arthritis that is associated with connective tissue disorders, and it can come with skin diseases, which is very, very difficult for people to comprehend. Oh, I've got a skin disease, why do my joint hurt? And it's important to know that there is a lot of connection here. The other bit that I want to point out is you can have more than one arthritis. So for argument's sake, you may have osteoarthritis, and you may have rheumatoid arthritis, and you may have gout as well, if you are very unlucky. So don't be fooled by, if you've got one type of arthritis, you may not have the other one. Okay, so how do we go about diagnosing arthritis? That's a dilemma for us doctors. And I think the first port of call, when you go to your doctor and your doctor says, oh, Mr. So-and-so, you probably got arthritis. The first image we got is, oh goodness, I'm going to have a stink tomorrow morning, yeah? Oh, my joints will be deformed and I will be walking. Or maybe I will have a Zimmer friend in my house and let me ring my son to say, hey, come on, you need to do something about it. Doctor has told me I've got arthritis. And then you ring so-and-so and say, sorry, I can't come out. My doctor said I've got arthritis. I need to stay in because it's raining. All sorts of images. And the worst of all is to come past my dreaded receptionist to come and say, I need to see Dr. Kakad. He told me I've got arthritis and I need to come in whenever I've got pain. Who are you to tell me I can't see him? Yeah? All these images go through it. Fortunately for you guys, this is not a common occurrence. It happens, but not that often. So if somebody gives an arthritis diagnosis, fine. A lot of you have got arthritis, you don't have symptoms, fine. So do not be frightened when you get that. So when you eventually land up in front of me, the first thing we do is to really have a little chat with you. And in this country, we've got general practice, which is God's thing. And he knows more or less all about you since you've been with him. And you stay with him for a long, long period. So that helps in diagnosis. And sometimes people wonder, okay, he didn't ask me that, he didn't ask me that. Quite true, he didn't. And he didn't because he knows you so well. He knows your parents, he knows your children. So there's no need to ask you lots of questions. Occasionally he will examine you if it's necessary. Very often we do get a very good picture from when we talk to you. And my professor always told me, if you listen long enough, 65% of the time you do not need a stethoscope and you need only your fingers. Just listen, sit and listen. But unfortunately, you came to my surgery and I got 10 minutes. 3 minutes have taken for you to get to reception to my room. 2 minutes to talk about the weather. So you only got 5 minutes. Yeah. Very often I don't put my hands on it. But quite often it is not necessary. But it's good, very often we will examine it. The next 3 topics, i.e. blood test, not always necessary, but after speaking to you, after listening to you, after examining it, if I find that I have a doubt, whether you've got gout or rheumatoid arthritis or osteoarthritis, I may send you for some blood test, I may not. It is what my impression is. But the thing which worries when people come to me is x-rays. And they would come to me and I'll say, oh, Bartiban, arthritis check. They go home. Suolo mo doctor. Dai nahi, extra to karayo nahi. Arthritis credit. Very true, very true. To be honest, arthritis plays a very little part in diagnosis. Very, very little part. And unfortunately, you expose yourself to radiation. So I'll give you a classic example. If I were to take an X-ray on your chest, to see whether you've got pneumonia. And if I were to take an X-ray on your spine, the amount of radiation I give you for an X-ray of spine is 12 times the radiation you get for an X-ray of your chest. It is that much. And the information I get from it is 0. Okay? So very often, X-rays do not contribute to your arthritis. But unfortunately, people like ordinary people come and see us. They have the fixed idea that if I do not have an X-ray, I do not have an arthritis, which is absolutely wrong. Okay. And I think the other bit most of the people come to me with back problems and knee problems. So my doctor didn't send me for an MRI scan. Google says I must have MRI scan, otherwise you don't know. MRI scan and the symptoms you have got have very, very little correlation. So for argument's sake, your MRI scan will say, you get a trapped nerve. That's a common term you understand anyway. We say prolapse disc. So we are clever people, doctors. And you may have a prolapse disc, you will have no symptoms. You may have a point where you have absolutely A1 MRI scan, and you can hardly walk one step in front of the other. Okay? There is no correlation. So if your doctor does not do an MRI scan, you can still diagnose a slip disc. And if you have got a slip disc, you do not necessarily need an MRI scan. But do not be fixated on the investigations you need to be offered to come to a diagnosis. Okay? So now we reach the stage where clever Dr. Maya, like me, has got an idea, you've got arthritis, and I've told you what it is. So now we come to the crucial part, which all of you are interested in today. Again, another dilemma for me, how do I treat you? To tell you the fact that my father was an avid sun reader. Any of you sun readers here? No, don't raise your hands up, just say And I was a young qualified doctor, and I told my dad, I said, Daddy, I've been now given a job as a specialist in arthritis in my hospital. He said, yeah, very good, sonny. Have you read this? WD-40 cures arthritis. And he says, look here, that says this, he uses it in his wrist. It works very well. And you tell me arthritis comes when you get friction. Right stuff, isn't it? Okay, so these headlines very often is there to sell newspapers, yeah? It has no meaning. And most of these are not research or have no documentation to prove that it works. So please, for God's sake, talk to a doctor rather than listening to some. Okay? Okay, so finally we do come to a diagnosis, and quite often we give you tablets at first port of call because it seems to be a reasonable way of treating it. And unfortunately, if you're in France, you don't get tablets for arthritis, you get suppositories, okay? Same stuff, put up the back passage. So when you take things, and again the tablets we give you depend on the arthritis you got. And very often the first port of call would be the relief of pain, because that's what you come to me for. And we will give you a simple painkiller, paracetamol for argument's sake, or Panadol for those of us who are from East Africa. If that doesn't work, we probably will give you anti-inflammatory tablets. You're probably familiar with Nurofen or ibuprofen. And then going up, if that doesn't work, we give you opioids like codeine tablets, or codeine and paracetamol mixture. And very often that will be all that you will need. There may be an occasion where that may not be helpful, so we give you slightly higher morphine-based some, tramadol may be another name that we use, we will give you. But the important thing, especially I find in Asian communities, unfortunately I do not have many patients who I deal with an Asian community, but when I come to the gathering like this, "Mara doctor ne dawai pe kya kam karti?" When you say, "Benji su aipu?" "Ah, then safed goli aipi." So when I read it, paracetamol. કેટલી લેવાની છે? ઓ ઈ તો મને કે 8 લેવાની છે, પણ 8 લેવાય કે ગરમ પડે. બેન કેટલી લ્યો છો? ઓ સવારના એક લઉં છું ખાઈ પીને. શું ખાવશ? કીધું ને થેપલા ને ચાય. એક પેનાડોલ લેવાની, એક કામ. બરાબર? પછી દીવાબત્તી કરીને પછી શું મહેનજી તો ખબર પછી આ હું આસ્થા જોઉં, કથા જોઉં. પછી પછી આમ તમારા ભાઈ હોય એટલે ઘરે એટલે પછી અમે જરાક ના જમીએ બરાબર, પછી કે જરા આરામ કરું બરાબર, પછી ગોળી બીજી ક્યારે લે તો જમીને રાત્રે 24 hours બે પેરાસેટામોલ કામ નથી કરતી. ડોઝ છે 8 ગોળીનો. રમાબેન લઈ 2 ગોળી. આર્થરાઇટિસ નાખતા. કહેવાનો મતલબ શું છે કે તમને ડૉક્ટર ગોળી આપે અને જો તમે પ્રોપર ડોઝ ના લો તો તમને ફરક પડવાનો નથી. હવે તમને સવાલ, તમે પેનાડોલ 8 લેવાની, પેરાસેટામોલ 8 લેવાની, બ્રુફેન 3 લેવાની દિવસમાં. Which is more harmful? Brufen is more harmful, not Panadol. Only 8 લ્યો છે. That's okay. It's less harmful than 3 Brufen. So, message is this. Please take the medicines as prescribed. If it doesn't work, then go to your doctor. Don't be your own doctor. Okay. Rheumatoid arthritis is slightly different. In this, we give you medication to suppress your immune system. And most of these immunosuppressants we use in cancer treatment. So when you Google it, you're giving methotrexate for argument's sake, when you Google it, it doesn't come as treatment of rheumatoid arthritis. It comes as treatment of cancer. Yeah. So you come and tell your doctor, the Kotecha, one of the cancer, not in a cancer in the not true. Yeah. So please again, if you got doubts, clarify with your doctor. Do not go and talk to Google or don't talk to your next door neighbor, because that is not true.
Okay.
Rheumatoid arthritis has come a long, long way. When I was a young doctor, the only medicine we used was gold injections and some other tablets. Now we got biologicals, which is monoclonal antibodies. And this has revolutionized the treatment of rheumatoid arthritis. And now, if people are started early, and this is the emphasis we place, the early treatment, the better the prognosis. In other words, the earlier you get started on these treatments, the better the prognosis. You can go on for a long, long time. So, rheumatoid arthritis has come a long, long way. Rarely do we need an operation. And this is another bad bug for our Asian communities. Raman bhai ne operation kari દીધું. મારા doctor મને મોકલતો જ નથી. True. Majority of the time you do not need an operation. The operation is a last resort. An operation very often will not relieve your pain. It may relieve your mobility. An operation is always a risk. Doesn't matter. There's nothing like a small operation. Operation is an operation, full stop. So do not be under the impression that operation is the only one that will cure your arthritis. There is no cure for arthritis. You can only control it, you can manage it, but there is no cure. So if somebody says so-and-so's arthritis has cleared up, it hasn't. It is like a volcano. It is salient, but it will erupt. Your arthritis will eventually come back. So don't be under the impression that arthritis is curable. Okay, now you will see the slide in the middle, copied by all three speakers today, because all of us, that is the biggest problem we get in Western world, is obesity. The more weight you carry, the more damage your joints get, the more problems you have. So obesity is the one we need to tackle. So no samosas, no tapelas, you know. Okay, and how to deal with it? Diet, okay. Now, Dr. Kotecha is going to speak about obesity, so I'm not going to dwell on it. Diet, the previous speaker has said something about it. The only evidence we got in terms of treating arthritis is that Mediterranean diet does help certain type of arthritis. We do not have proof, but this is anecdotal evidence. That's what we heard. And sometimes it is so sensitive that some people will say, I eat certain food and my arthritis gets worse. It's true for that individual, but it is not universal. So by all means try, but don't be paranoid about it. Don't think that you have to try. And it doesn't help, that's fine, you try. Because it helps somebody else, it may help you. So worth a try, but not rely on it. I think the most important thing you guys can do is to keep mobile. Keep your joints mobile. The secret is, the more mobile your joint is, the better service you get out of it. And you don't have to go to a gym. Right? Most of us are over 40s, we can't go to the gym. Yeah? It's for youngsters. You and me, the gym is up and down the stairs. Good gym. Go in the garden, just gym. Go and cook a meal, just gym. Don't play with remote control all the time. Okay? Keep your joint mobile. That is the secret. Don't sit in the settee in one place. Just move in the house. Just do something. Just find some excuse to get up, some excuse to do something in the house. That is good enough. But use your joint. The more you use your joint, the better there will be. The less medication you will require, the less stiffness you will get. So please, my take-home message, if nothing else you take from my talk today is, if you got arthritis, please, for God's sake, do some sort of physical activity. Okay, so we have come to a diagnosis. We've seen what to do. What can we do about people who have got arthritis, unfortunately, this is a progressive disease. We can just only slow it down a little, but it is certainly a progressive disease, and you will get more and more and more disabled as you get on. And there is nothing today that you cannot find to help you if you look hard enough and in the right place. So people with rheumatoid arthritis, for example, their small joints get very deformed, so they're not able to hold a fork or a knife or a spoon. You get now a knife and spoon which are big handles, which you can use, and they're very cheap to buy, they're not expensive. And then they don't have to rely on anybody to mix their food for them, make the bowls for it. Gentlemen, people like shaving, I mean, you get quite a nice shaving kit which you can use with your rheumatoid hands and shave yourself. You don't have to rely on your son or somebody else to help you to shave yourself. So there are devices out there which you can purchase at very, very reasonable cost. If you do not know what they are, and if Google doesn't tell you, then go and consult an occupational therapist. Your GP surgery may have this address, your hospital surgeries may have this address, your councils, local councils may have the address, and they will give you practical tips. The other common problem, as I said, is people, when they get a little bit further on, is to getting up from your chair when you're sitting down. You may have a stick, go and buy it, it's very cheap. Or you can raise a settee, very easy to raise it. People get difficult in getting steps, get handrails put up in your front door, quite cheap. Get your handrails in your bathroom, in your shower. Have a walk-in shower, don't go into the bath. Taps, you can have connections to a tap which you can use with your elbow, you don't need your hands. There are loads and loads of gadgets there which you can buy at very reasonable cost, but that will give you an independence, and that is the most important thing. If anything irritates people around you, is your dependence on them. As soon as the dependent goes, and as soon as independent, that makes everybody's life so much easier. And these devices and these adaptations cost very little, very, very little. So my advice to you guys is, any disability you experience, if you've got arthritis, you've been adequately treated, and you come to the end of the road, go and look for devices which makes you independent. More independent you are, the better you will be. I'll put up that picture there which shows a lot of things, but one of the important things I wanted to tell you about is DVLA. I mean, I'm told North Rwanda community is quite rich and everybody has got 3 cars at least, if not more. If you've got arthritis and you're driving, and if you had your car adapted, or you got your car under a scheme called Mortability Scheme, it is very important that you know, let your DVLA know, or you let any of your insurance company let you know. A, you will get a concession on your insurance. B, mortality schemes are there to help people to be mobile, and there are lots of benefits attached to that scheme. So you can benefit all financially as well as maintain your mobility. But the most important thing here is that you can still continue to drive your car as long as you want. So there's no limit on this one. So it doesn't matter how debilitating the arthritis you go, you can still be independent. So that was the message I wanted to really say. I think I've spoken long enough, and I think you're tired listening to me. So I will bid my exit, and I thank all the organizers for inviting me here today, and I hope you gain a little bit out of what I say today. Thank you very much.
Very entertaining talk, and thank you for dispelling some of the myths that we all have. And we're going to take 2 quick questions. You will be upstairs for the consultation room, so if you do have any other questions, we can ask those there. So 2 quick questions if we have any. No?
Doesn't seem like it. I think WD-40's obviously done the job.
We've got 1 here. We'll do 1 question then, please.
You didn't say anything about preventative. Can we do something before we get diagnosed for the arthritis to prevent getting? What can we do?
Yeah. Okay. The only preventive measure you can have is in osteoarthritis. Rheumatoid arthritis, the answer is no. Gout, the answer is no. The other type of arthritis that I briefly mentioned, lupus, is no. The only one that you may be able to prevent is osteoarthritis, or I wouldn't say prevent, but delay getting arthritis. And again, the message here is your weight, your mobility. And those are the only two fundamental things you can do at any age. But unfortunately, you cannot prevent arthritis coming. It is coming.
Thank you again, Dr. Kakad. And we'll do one
second. I'll answer this question. There's a mic here.
Just wanted to ask, what are your views on turmeric as an option to relieve arthritis?
Okay, turmeric is an anti-inflammatory substance. And one of the components of our inflammatory arthropathy, this is a medical term, but where your joints swell up, become painful, is inflammation. So there is evidence it helps. There are no trials published in turmeric. Just to divulge slightly, chilies is an anti-inflammatory substance. And nowadays you get paste, which is chili-based. Yeah? So I'm sure turmeric will be researched a bit more. It is an anti-inflammatory tablet. It may have a systemic effect as well. So there is anecdotal evidence, there is no proven trials.
Great, we've got one more last question, I think.
With immunosuppression, with immunosuppression, would you look at T and B cell function at all?
Sorry, beg your pardon?
With immunosuppression, which you mentioned about monoclonal antibodies, and would you look at the T cell and B cell function? Because with immunosuppression, you get depressed immunity, particularly the T cells and B cells.
Yeah, T cells and B cells, again, we don't look at it in diagnosis. But we're certainly aware that they do play a part in an inflammatory process. But when we're investigating a person, we don't. We look at antibodies of these diseases to prove the disease, but while we're treating it, what we're monitoring is the side effects of the medication. But we don't look at it for diagnostic purposes.
Might be a good idea to do that, actually.
Or maybe. I mean, I'm not aware of any trials that are ongoing at the moment. If you're aware of it, let me know. I will try and look into it.
Okay.
Many thanks.
Okay. Thank you very much. I know there's possibly a burst of questions, but Dr. Kakad will be upstairs. So thank you again for your time, and let's give it a call. I just want to bring Dinesh back to the stage. He's got an announcement to make.
Thank you very much. The next announcement is something I'm very privileged to do. This is a young man who I worked with back in 1993 when, dare I say, he looked 16, but he's a little bit older. He's done so well for himself. He's recently been elevated to the position of a peer, appointed by his government Theresa May, for the wonderful job that he did. He is the youngest peer. He is at the age of 46, amongst 800 peers in the House of Lords who average the age of 69. He is. But you know, the proud thing is he's a Lohana. So, wonderful job there. And he wrote wonderful speeches for me back in 1993. He masterminded my talks when I was on the radio or television, etc. But I'm also privileged that at the same time, only last year, he handcrafted the speech that our very beloved Prime Minister of India, Narendra Modi, read at the Wembley Stadium with Mr. David Cameron being present. Ladies and gentlemen, can I please warmly ask you to warmly welcome our very own Lord Jiteshbhai Gadhia. Thank you.
Thank you, Dineshbhai, and also Vinodbhai, for your very kind words and your welcome here this morning to participate in this fantastic medical camp. In fact, I missed the one last year, and I heard some very positive feedback on it. So I'm really glad to be here in person this year to see all the activities and indeed hear some fantastic presentations by the previous two doctors, Dr. Rajani and Dr. Kakad. And I think you have another two in store. So you've had hypertension and arthritis, and I think you're going to move on to obesity and oncology. And it's great to see this initiative and seva being undertaken for the community, by the community. and it certainly lives up to the reputation that I heard about previously. And so I commend and congratulate the entire team. I know it takes a lot of effort to put something on like this, and I think we should all give a round of applause to everyone, including, I would say, also the medical professionals who have given up so much of their voluntary time. So you're here to listen to them and not to me, but I just wanted to make a couple of brief points. So health awareness is something that I've had a personal long-standing interest in. I served for 10 years between 1999 and 2009 as a trustee of Guy's and St Thomas's Charity, which is the largest NHS endowment, and in that capacity I saw a lot of stuff around various different therapeutic areas. And in addition to what you're going to be listening to about today, I also took a very keen interest in diabetes. And if I don't know if Amrullah Bhai is here, but Sanjay and Pratibha Ben is here. And when they asked me at that time to take an advertisement out in the annual Raghuvanshi Diwali magazine, I told them, look, I don't have anything to advertise. But instead, I'd like to donate the space to a charity called Diabetes UK, who at that time had actually launched a very innovative educational Bollywood DVD in Hindi called Meethi Baatein, or Sweet Talk, and it was really to raise awareness about the disproportionate impact that the incidence of type 2 diabetes has among South Asian populations. And we're actually 6 times more likely to have diabetes than the wider population. And those who do have diabetes are 3 times more likely to have heart disease, and I think it's 4 times more likely to have kidney failure. And I think, as Dr. Rajani was saying, some of it's genetic, and I think it's to do with the way our bodies store and burn fat, but also a lot of it is, as she's quite rightly said, to do with our lifestyle and diet, and that's relevant across a number of these different areas. And the second point I wanted to make is that an initiative like this not only provides a very tangible and practical benefit for our community, but it showcases the fantastic talent we have in the healthcare and medical professions. And only last Thursday I was in Parliament at an event hosted by Bob Blackman MP, and in fact Dr. Kotecha was there as well, and it was the first ever gathering of chiropractors in Parliament, which was led by one of the members of our own community, Dr. Lalit Sora. And it was very well attended. And at that event, I highlighted that out of 280,000 registered doctors at the General Medical Council, 12% are of Indian origin. And that is 5 times our representation in the overall population. And we see a similar pattern in dentists, in pharmacists, in nurses, and opticians, and we really made a truly outsized contribution in all these fields. And it's no exaggeration to say, I think, that without the talents of the British Indian community, the NHS would simply ground to a halt. Wow. And we should be proud of the contribution. So look, I'm really pleased to be at this medical camp. I hope it's going to become an annual fixture of the LCNL calendar. I hope in future that you will do other things like, just to give you a couple of examples, we proportionally, I was thinking things that we represent more of, or we underrepresent in terms of blood donations and organ donations. And I think we should maybe in the future focus on that. I think we should also focus on some of the exciting technologies that will help us monitor on a continuous basis some of these things. So I heard feedback from the medical, or effectively electronic devices conference that takes place every year in Los Angeles, and it just took place in January this year. And there is a ring that has been devised which can actually monitor on a continuous, we all have Fitbits, the ring that can actually monitor on a continuous basis your blood pressure, your heartbeat, in fact even your blood sugar levels. And I think maybe we can have some information on that. So congratulations again to everyone involved, and I hope this becomes bigger, better, and more ambitious every year. Thank you.
Thank you.
Thank you, Lord Gadhia, and we hope to see more of you in the future, I'm sure, at our events. So it gives me great pleasure to introduce the next speaker, Dr. Sanjay Popat. He's a consultant medical oncologist with both private and NHS practices at the Royal Marsden Hospital. So he's a consultant thoracic medical oncologist and honorary clinical senior lecturer in the molecular genetics and genomics group at the National Heart and Lung Institute, Imperial College London. He's internationally recognised expert in the treatment of lung cancer, mesothelioma, and cancers of the thymus, namely thymoma and thymic cancer. Dr. Popat qualified from Guy's and St Thomas's Hospital in 1994, completed general medical training at the Royal Brompton and the Hammersmith Hospital, and medical oncology training at the Royal Marsden. He was awarded a PhD in molecular genetics in 2002, and thereafter he undertook a postdoctoral clinical fellowship and subsequently a clinical senior lectureship. He's quite well internationally known and been awarded prizes and published in various areas, including molecular genetics, therapeutic biomarkers, and medical oncology. So please put your hands together and welcome Dr. Sanjay Popat.
Well, thank you very much for that wonderful introduction. You'll be pleased to know I'll keep things quite simple today. So, Jai Swaminarayan, Jai Siaram, and Jai Shri Krishna. And I'm giving this talk also on behalf of one of the other hats that I host, which is part of the healthcare team at BPS Swaminarayan. So I've been asked to speak to you today about oncology, and I think what I'd really wanted to do is to give you an overview about what cancer is, what it means, and dispel some of the myths that we hear about on a day-to-day basis with oncology. So we'll talk about what exactly is cancer, what causes cancer, how do cancers develop, how can cancer be treated, how can I prevent cancer from occurring, and a few myths and facts. So what is cancer? The first thing, cancer isn't just one disease. Cancer is actually thousands of diseases. It's a group of related diseases, all associated with the same fact, that our cells within our body grow and divide. And you can see on the panel on the left-hand side, that's an example of a human liver, which has been sliced, and you can see the white blob in it, and that's a lump of cancer, which is growing when it shouldn't be. So when I say to people that cancer is all due to our cells, most people don't really know what cells are, and that's fair enough, why should you? So our body is made up of thousands and thousands and billions of cells, and they're all totally different. We have cells in our bone, we have cells in our lung, we have cells in our heart, we have cells in our muscle, we have cells in our pancreas, we have cells in our liver, and these cells grow and divide in a normal way. These cells are born, they grow, they divide, and at some stage when they've got a bit old and tired, they die. That's what happens normally. But in cancer, what happens is when the cell grows, it becomes slightly abnormal. And instead of dying, it carries on growing. And when it should die, it doesn't. And then it carries on growing. And then after a while, it decides, hang on, I'm going to divide into two cells. And those two cells carry on growing. And they divide, and they become 4 cells. And they divide and become 8 cells. And then it carries on. And so from a very tiny microscopic abnormal area, after a period of time, you have quite a large lump developing. And if you don't do anything about it, it's going to carry on growing. So what do we mean by cancer? Well, people call cancer many different things, but really what I'm talking about here is what's called malignancy or malignant tumours. And these are cancers or growths which not only grow, but they go to other parts of the body, and that's the critical issue here. So what you see on the panel on the left-hand side is the cells in our body. You can see the yellow-coloured cells, but in the middle of it, you see the blue cells. They're the cells, you can see they're not growing properly, they're larger. They're not growing and dividing in the normal way. And if you leave that over a period of time, they'll grow outwards and become a lump and grow inwards into the body. And the problem is when they grow inwards into the body, they can get into the bloodstream and in the lymph system. And that's when trouble starts to occur, because these cells will grow and go to other parts of the body, such as the lungs, such as the liver, such as the brain, and such as the bones. So one of the things that people always say to me, you know, there's a real cancer epidemic. I know so many people with cancer, and we have more and more people I'm hearing with cancer. I go to the centre, and Kakad, and he's got cancer, and Biju, he's got cancer. You know, there's an epidemic here. But actually, you know, there is no cancer epidemic. We just are more open about cancer now than we ever were before. We've got amazing statistics in the UK, which go back decades. There is a slight increase in cancer, but that's because we're living longer, and cancer is a disease of the elderly. There is a very slight increase, but that's because we're richer than we were in the war years as a country. But such as an epidemic, there's no such thing. Cancer affects 1 in 3 of us. So everybody in this room will know somebody who has cancer. But the most important thing is you'll hear lots of damning statistics about how cancer's a disaster, we're performing worse than everywhere else in the world. The one thing that you must know is we are curing more and more people with cancer today than we ever have before. And the biggest issue we have now is people living with cancer and people who've been cured with cancer, because they have issues with side effects and other issues as well. So one of the reasons that cancer is more commonly thought to occur is that we're living longer. Our average age of survival in the population in the 30s and 40s, very few people made it into the 60s. We're now living into our 80s, and many of you who read the papers will have seen the report which says in Japan and Korea people are going to live into the 90s. We are going to undoubtedly see more and more cancers. That's because we're living longer, and as we're living longer, our cells in our body are living longer as well. And the longer our cells in our body are living, the more likely it is that they're going to become abnormal. And an abnormal cell turns into a cancer cell. So cancers can occur in any part of the body. So I started by saying that there's not one thing called cancer, there's many different diseases called cancer. But actually, cancer can arise in any part of the body. It can arise in the lung, where it's called lung cancer. It can arise in the breast, it's called breast cancer. It can arise in the colon, it's called colon cancer. It can arise in the bladder, it's bladder cancer. And prostate cancer. These are all totally different diseases. They're treated totally differently. And in fact, each of these diseases is not one disease. Lung cancer, for example, is at least 300 different diseases, depending on what type you've got. These ones on the left-hand side are something that you might read about called a carcinoma. Then we have cancers where the blood that we have becomes cancerous. These are called the leukemias. In our circulation, we know that we've got the arteries and veins, but next to the arteries and veins, we have a different type of circulation, which most people don't know, called the lymph system. And there are little stations in the lymph system. These are called lymph nodes. And these stations can become cancerous, and that's called a lymphoma. That's a very different type of disease. And even your bones and your muscles, we've heard that they can become a bit dry. We need a bit of WD-40 to keep them oiled. But actually, you know, they can become cancerous as well. That's a very different type of cancer. These are called sarcomas. So what causes cancer? Well, it's the usual things that we've heard about. Smoking is by and large the biggest cause of cancer. And you'll be amazed at how many people don't believe that, actually. They used to say, yeah, you know, Kakad was smoking till he's 90, and I want to you know, cigarette no super. You know, there is excellent evidence that smoking causes cancer. I'm a lung cancer specialist. I see 10 new diagnoses of lung cancer a week on average, and nearly all of those would have started smoking in their teens. And we see the same problem in many other different types of cancer. So the one thing that we can do as a community is to stop our children from smoking. And those of you that are smoking, you may say, well, you know, like, get if you give up today, your risk of developing cancer will come down markedly over the course of the next 5 years. So assuming you're going to be alive in the next 5 years, of course, then your risk of developing cancer in the future is going to massively reduce. So it's absolutely imperative that smoking is reduced. We've heard a lot about diets, and that I think is the common thing throughout this afternoon, and I'm as guilty as everybody else is. But we have to ensure that we're eating a well-balanced diet and eating lots of fruit and vegetables and reducing all of the things that cause weight gain and cause hypertension and cause arthritis. We know that we should be eating at least 5 portions of fruit and vegetable, and some of you will have read 10 portions of fruit and vegetables are useful. I was at a seminar with the author of that report on Wednesday, and we were discussing that in great detail, but certainly there's very good evidence that we should be doing that. And only if we do that will we get our weight down to what the acceptable weight is. So we should all know what our body mass index is and try and get down to an appreciable weight. Alcohol. So as we're getting richer, as we have the younger members of our community, we're drinking more and more. Undoubtedly there are a normal amount of alcohol that's allowable, but in excess of that we see cancers arising. And there are a number of other factors, such as sunlight exposure. But in our community particularly, it's that thing at the bottom there, sopari. This is the biggest problem we have in our community. And it's not just the Lohana community, it's the Indian community in general, Pakistani community in general. Actually, you'll be surprised to know that sopari is actually highly prevalent in the Taiwanese community as well. So, a lot of people will say to me, you know, these are the people that come to my clinic with head and neck cancer. If you have sopari in your mouth all the time, you are directly applying a cancer-causing chemical to your tongue, day in, day out. It may taste nice, for sure, fair enough. But then don't be surprised when 10 years later you develop a cancer in the throat. That's what happens when you put a cancer-causing chemical in your throat. So the most important thing to do is try and at least cut it down, if not get rid of the sopari element entirely. So people say to me, oh, why do I need to worry about cancer? Because you're man Taiwan or Taiwan. Well, that may be fair enough, okay? But cancer is curable, okay? Do not think that as soon as you have a diagnosis of cancer, it's terminal. It is absolutely curable. So the important thing to do with cancer is catch it early enough before it's gone to other parts of the body. And that's really important because you've got to get it cut out. Because cutting it out by surgery is the best way of controlling it and getting rid of it. And you can only cut it out if it has not spread to other parts of the body. And then when you go and see a surgeon, he's going to say, what's your blood pressure? So you've got to make sure that the blood pressure is good. And he's going to make sure that you can get onto the surgical couch to be examined. So you've got to make sure that you're generally fit, so the arthritis is okay. And he's got to make sure you can fit in the scanner, so you know what's going on. So your obesity levels are going to be okay. So you've got to have general health to make sure you can get on top of cancer. So, how does an oncologist diagnose cancer? Well, the oncologist doesn't diagnose cancer. The oncologist is the guys that ends up treating it. It's usually the specialists, the GPs and the other physicians that end up diagnosing cancer. So how does cancer make itself aware? Well, you can be lucky in some respects and you can have a lump. And in some ways that's quite good, because in ladies with breast cancer, you can feel the lump quite quickly. And it's a very early cancer, you can cut it out, very high chance of cure. You could be unlucky and the lump could be growing inside. And if it's growing inside, it's going to be silent. Once somebody suggests that there might be cancer on board, you'll be quite worried. But we should be thankful of our NHS. We hear lots of bad things about the NHS, but actually one of the good things of the NHS is the fast-track system that the NHS has. As soon as a GP suspects that you've got cancer, you will be seen by a specialist in the hospital within 2 weeks, 14 days. And as soon as that referral is made, the clock starts ticking, and me has 62 days within which to get all of the tests organised and get your treatment started. Okay, that is a metric that each hospital is measured on, and if we do not meet that hospital, our funding the next year drops down. So you can bet your bottom dollar we make sure that every patient is seen within 2 weeks and gets the start of their treatment within 62 days of an urgent referral. But in that time, once you've been referred, you've got to have scans, you've got to have a biopsy, you're probably going to have more scans, you may need another biopsy, your sample has got to go from one hospital to another hospital, you've probably got to go to 3 different hospitals to get different tests done, so it's quite a complex period of time. Some of our patients aren't well enough, they're not lucky enough to have a lump on their skin or a lump on their body. The lump's inside and they can get quite sick quite quickly. And these patients come to hospital through 999 as an emergency. Those patients are not very well. And so the important thing to do is, if you're not well, be in touch with your GP, be in touch with your doctor, be in touch with your pharmacist. Because your pharmacist probably sees a lot more of you than the doctor's does. And actually, we've done a lot of research looking at this, and pharmacists pick up cancer-related phenomena quite quickly. So how is cancer treated? Well, cancer is not treated anymore by one person. It's decided by a multidisciplinary team, because the treatment of cancer is quite complex. So you need a number of different people sitting around the table looking at exactly what has the patient got to work out what the right treatment is. By and large, you want to have a surgical opinion. You want a surgeon to say, can I cut this out? Is the patient well enough to cut it out? Or has the cancer already gone somewhere else? And so there's no point cutting it out here. Then you might need to see somebody like me, an oncologist, and I'll be speaking to you about, well, I think you need some sort of drug treatment to get this under control. And when we say drug treatment, everybody usually says chemotherapy. But actually, chemotherapy is yesterday's treatment. We've got lots and lots of treatment that we're using now. Things like biological treatment, molecular targeted treatment. We've got things like immunotherapy, which are making huge impacts in how we treat our patients today. You might need to see a radiation oncologist. And a radiation oncologist will put you on a couch and give you high-dose X-rays, radiotherapy. And there are certain types of radiotherapy which are even potentially replacing surgery, because some patients, they can't have surgery because they're so unwell, so we treat them with very focused radiotherapy. And at some point, if you go to a large cancer centre, some nurse may come up to you and say, listen, are you interested in taking part in a clinical trial? And this is the commonest question I get asked. I get a telephone call saying, "Alo ko mane wat kari che, like information sheet type che ke clinical trial che. Su experiment che, guinea pig thau chu ke buche." So this is a really important area of research, because actually what we're trying to do in research is make sure that we improve our outcomes, and we do that in a safe, coordinated and highly regulated manner. The way we do clinical trials is governed and enshrined in law. Actually, clinical trials have a lot of benefit. It allows us to give tomorrow's treatment today. I'm treating patients with clinical trials with compounds which don't have names. These drugs have numbers. So there's a trial, for example, which we did a few years ago. We gave patients about 2 years ago a compound, a drug called AZD9291. 2 years later, it's an international standard of care. Those patients receive that drug 2 years ahead of everybody else. So these are the advantages that clinical trials can give. And the other thing is, actually, if you're in a clinical trial, you'll be much more carefully monitored by the team than you would as the standard care. So actually it's a totally safer system of being looked after. But the biggest question that most people say to me is, how can I prevent cancer from occurring? And the answer to that is screening, screening, and screening. The NHS provides so much for us, and our community, the Indian community in general, is awful at taking part in screening. Screening is there to make sure that we pick up cancer whilst it's small and before it's gone too far, to make sure that the cancer can be cut out and treated and we can cure patients. It's free. You get the information in the post to your home. You don't even have to go anywhere to find this information. We track you down and hunt you. But yet, even despite that, our Indian community does not participate in screening. This is the biggest problem we have with our community. So, the NHS funds 3 screening programs. Bowel cancer screening. From the age of 60, everybody in this room will be invited to give a stool sample. I know it's not pleasant, but please do it. Because bowel cancer is common. It's extremely common, and you won't know about it until it's too late. So let's pick it up with our stool sample, get it cut out, you'll be cured. Breast cancer. From the age of 43, women are invited for regular mammograms. One of the biggest questions I get asked is, it's absolutely critical, because elderly females are the target group who are most likely to get breast cancer. And if we pick it up early, operation done, dusted, finished, don't need to worry about it. Cervical cancer screening for women. Ladies, I know you don't like going to the GP and having the cervical screening, but it is so important, and it's offered from the age of 24 onwards. Many people say to me, I'm not at risk of this, I don't need it, but you will be if you're in a relationship. So a few myths just to bust for you. So the common myths that are out there, and I'll just clarify for you. Do cosmetics and toiletries cause cancer? Is it the deodorants that I'm putting? Is it the talc that I'm applying? Because obviously talc is a chemical. If I'm putting it in my armpit, that's going to cause breast cancer, isn't it? No. Let me tell you now. Toiletries and cosmetics do not cause cancer. I'll tell you that. Mobile phones. Mobile phone rakhu chu અહીંયા pocket માં અને પછી મને prostate cancer થઈ ગયું છે. એટલે મારો કાંઈ વાત નથી, mobile phone લેવાનું છે. Okay? Absolute rubbish. There is no evidence that mobile phone exposure causes cancer. It can cause a lot of problems, high bills, the fact that people won't talk to each other. It doesn't cause cancer. Okay? Other thing, I live next to a power line. I'm going to get leukemia or brain cancer. That's the other biggest myth that's out there. There are a lot of problems that living next to a power station will cause, particularly on the value of your property, but not anything to do with cancer. There is no evidence of that. Plastic in water bottles. Oh, I've got a very good water bottle. I am Amazon Matili Duce. It is certified clear, India Matili Duce, and the chemicals are nothing. Okay, well that's fine. If you want to spend your money that way, you do that. But actually, I'm quite happy buying the Evian from the shop in the corner and drinking it from that, because there's no evidence that any of the plastic in those bottles causes any problems. Stress. This is the commonest thing. So having a diagnosis of cancer is stressful, and actually having going through the process of being worked up to see whether a lump is cancer or not is incredibly stressful. The two things happen in common, and actually sometimes when there's a lot of stress in the family, that's when you start thinking about getting problems sorted out. It's usually not the other way around, stress causing cancer. Cancer is usually picked up at the time when there's a lot of stress going on anyway, and then you focus in on that. The human mind likes to have a cause for something, and often we think that stress is the cause for it. There is no evidence that stress causes cancer. It may cause blood pressure, that's a big issue, but not cancer. Other thing is cancer is man-made. Modern disease. Apne Africa માં હતા, India માં હતા, કાઈ cancer નો કાઈ વાત નથી. Okay, so actually that's rubbish because there's lots of cancer in Africa. It's just very poorly recorded. There's lots of cancer in India. There's in fact more cancer in India than there is in the UK. Cancer is not a modern disease. If you look at lots of case histories, lots of records, it's been dated back well in the 2000 BC, etc. Superfoods prevent cancer. I've got to have my blueberries, my kiwi fruit, my pomegranates every day. I've got to have my juicer to get this under control. Fine, that's very good, it's excellent, because it's all part of the 5 a day. It will keep the blood pressure down, it will keep the obesity down, excellent. But that by itself is not going to prevent cancer. It's the fact that your diet is good and that your obesity is down. Sugar feeds on cancer. This is the commonest question I get asked. When a cancer no diagnosis chair, sugar. Okay? Well, that's fine because your diabetes will be under good control. That's not a bad thing, but I'll tell you now, it's not going to do anything for your cancer. I'll tell you that now for a fact. I've had patients who've gone on 0-calorie diets, we've done scans, everything, it still carries on growing. There is no evidence of that at all. Other thing is that about the Western conspiracy chair, we're all hiding the cure. Tomorrow private practice, these treatments aren't working. Okay, other rubbish as well. I wish there was a cure out there. And about the treatments are tough. Tomorrow treatments, both side effects, the treatment is causing more damage than the benefit. Sure. The cancer treatments can be tough, but that's the job of the oncologist to work out whether the right treatment is the right treatment for you and your specific type of cancer. Because sometimes we have to give you tough treatment to try and cure this, particularly with the leukemias. And the other thing is I put that on their sharks because a lot of people will go into Holland and Barrett and ask for shark's fin supplements because there's a common myth out there that shark's fin supplements are very good at controlling cancer because sharks don't get cancer, do they? Well, of course they do. Okay, anybody will tell you they do get cancer. Okay, with that, thank you very much. I'll work to close.
So, thank you very much. That was a very thorough and informative talk. Unfortunately, we are running a bit behind, so if that's possible, we're going to save the question and answers for the consultation rooms upstairs. I know that cancer has or is touching a lot of lives here, so you may have lots of questions, but if you can find Dr. Popat upstairs, that'd be great. Thank you very much. Okay, so last but not least, for our 4 talks here, Professor Bhik Kotecha, I'd like to welcome you up to the stage. So Professor Kotecha qualified from Cardiff Medical School in 1994, and he became a consultant ear, nose and throat surgeon in 1995. He was recently awarded professorship from the Barts in London School of Medicine. His NHS practice is at the Royal National Throat, Nose and Ear Hospital in London and Queen's Hospital in Romford. He deals with most ENT problems, but he's developed a special interest in something that he's going to talk to you about, including snoring and sleep apnea. He's published over 100 articles, including textbooks, chapters in various books, and in peer-reviewed journals. So one of the areas that Dr. Bhik can cover is obesity, which is kindly agreed to do during the day-to-day. He's also been awarded numerous prizes, including a gold medal from the British Academic Conference of Otolaryngology and the Hospital Doctor Team of the Year Award. So congratulations and well done on that.
Thank you very much. I guess you're all hungry, yeah? So I'll keep it short. I hope that some of the content of the presentation doesn't put you off your dinner and kill your appetite, so I'll try not to do that. Okay, so I'm an ENT surgeon, so you're probably wondering why am I here talking about obesity. There are 2 reasons. First and foremost, one of my passions in life is to treat patients with snoring and obstructive sleep apnea, and a lot of these people tend to be obese. So I do know a little bit about obesity, but I'm only here because the person who's supposed to talk about obesity turned us down at the last minute, so I'm afraid you've got to put up with me. So, obesity and its huge impact. I'm sure you all know what obesity is, but for those of you who don't, I'll just touch briefly upon it. What are its consequences? Why and how does it happen? How do we fight it? So line 2 and line 3 should have been the other way around, but then I thought, no, actually it's important to understand what the consequences are. And if I can show you what the consequences are, hopefully that will frighten you and you'll work towards not becoming obese. So obesity is generally graded by the body mass index. And the body mass index is measured by considering your weight in kilograms and your height in meters. And 20 to 25 index is considered as being normal. Between 25 and 30 you're slightly overweight or pre-obese. And morbid obesity used to be BMI more than 40, but more recently it's thought that even if you've got a body mass index greater than 35, you're morbidly obese. Now there's a catch in here because ethnic variation comes into the equation. And unfortunately these figures are not for Asians. For Asians the figures are even lower. So we really are in a fix here because we've got to be very careful about our weight. And if you compare the males and the females, unfortunately ladies, the incidence of obesity is higher in women, and partly this is due to hormonal changes and things like that, but wherever you go in the world, women are thought to be more obese than the gents. So the bottom line is that obesity is excessive accumulation of and storage of fat. Now, Indian mythology is very fascinating, I'm very passionate about that, and I thought, well, how can I bring Indian mythology in here? So I thought of a character who both fulfills the criteria for sleep and appetite. So, who better than Kumbhakarna, who's the brother to Ravana and Vibhishan, to demonstrate this? And many of you probably know the story, but Lord Brahma wanted to give a boon to Ravana and his brothers. So Ravana obviously asked for immortality. And then they went to Kumbhakarna and they were wondering, I wonder what he's going to ask for. So Brahma was very scared that this guy might ask for things that we can't deliver, and we really have to be careful about what he asks. So we need for him to ask things that we think may be beneficial to the community. So he instructed Goddess Saraswati and said, I want you to submerge yourself in his throat and make him say things that will be beneficial for the community. So what did he ask for? I want a great sleep. I want to sleep for 6 months. And they thought this was great because he had an enormous appetite. His appetite was so huge that the gods were worried that if this guy carries on eating at this rate, there'll be no food left for anybody else. So we need him to sleep for 6 months and then eat whatever he can when he wakes up. Anyway, that aside, evolution of obesity. So this is what we call the obesogenic society. In this modern era of food, cars, TV, computers, inactivity, obesity is on the increase. In the good old days, food was scarce and exercise was the thing, so people were out and about. If you look at this trend in obesity, the top line here is relating to the females and the bottom line to the males, and if you look to the 1993-1995 data, that showed that 1 in 6 people were obese, and now it's almost 1 in 3. So the incidence is always on the increase, and there are lots of things that we need to worry about in obesity. So people think obesity runs in your family. Well, obesity doesn't run in your family. In fact, nobody runs in your family. That's what causes obesity. Now, when I told you that obesity wasn't my title, and so I was researching this in the last couple of days, and I came across this very interesting article from a family in Gujarat. And it can only happen in India. It was a father who has 4 children, and these are 3 of them. The eldest child only weighed 16 kilograms when 7 years of age. And this father has decided to sell his kidney to have all these 3 children treated in an obesity clinic. Sad, really. So what I thought, I want to demonstrate this message, and it's a take-home message, really. This is about the family, Yogita and Anisha. The 2 children that you saw, they eat 18 chapatis, 3 pounds of rice, 2 bowls of dal, 6 packets of crisps, 5 packets of biscuits, 12 bananas, and a liter of milk or Diet Coke or Pepsi per day. So I've got a brief video. It's a 2.5-minute video, but I think it's a very sad and touching video, but I'd like to show that I hope the sound is working on this one.
मेरे को 4 बच्चा है। पहली लड़की है, उसका नाम है भाविका, उसका वजन है 16 किलो। दूसरे नंबर की लड़की योगिता है, उसका नाम योगिता है और उसका वजन है 33.5 किलो और उसकी उम्र है 5.5 वर्ष। और तीसरे नंबर की लड़की है हमेशा, उसका वजन है 47 किलो। और उसके बाद 1.5 साल का लड़का है हर्ष, उसका वजन है 15 किलो। का पैदा हुआ था तब इतना वजन नहीं था, सब पैदा उसकी नॉर्मल डिलीवरी हुई थी और पैदा होने के बाद 3 महीने के बाद उसका वजन थोड़ा थोड़ा बढ़ता गया। लोग दूसरी बच्ची योगिता है, उसका वजन पहले बढ़ा तो हम लोग ने ऐसा सोचा कि उसकी सेहत अच्छी है इसीलिए इसका वजन बढ़ता है, लेकिन ऐसा नहीं हुआ, वो उसका बढ़ता रह गया। उसके बाद तीसरी बच्ची हुई हमेशा, उसका भी नॉर्मल डिलीवरी हुआ। डिलीवरी के समय जब पैदा हुई तब उसका वजन था 1 किलो 600 ग्राम हमेशा का। उसके बाद वो 3 महीने के बाद उसका वजन थोड़ा थोड़ा बढ़ता गया। एक पूरा दिन में 1 2 3 5 बार आती है पूरा दिन, सुबह से शाम तक उसको 5 बार रोज खाना पड़ता है। मेरी बच्ची एक दिन में सुबह से शाम तक खा जाती है और एक आदमी 2 से 3 दिन चला सकता है, इतना वो ज़्यादा खा जाता है। तो सुबह में पूरा दिन में गेहूं की रोटी, बाजरे की चपाती, चावल, सब्जी और मैं तो ऐसा मानता हूँ कि एक दिन में 1 केजी तो चावल खा जाते और चिप्स और कोल्ड ड्रिंक्स कोई भी लो तो एक आधा 1 लीटर 1.5 लीटर की कोल्ड ड्रिंक भी पी जाती है एक बच्ची। तो उसके लिए मेरे को करना पड़ता है क्योंकि मेरी बच्ची है, वो इलाज इसका नहीं होगा तब तक तो खाएगी, नहीं खाएगी तो जी नहीं पाएगी। इसीलिए मैं जो मेरे पास मेरे को मिलता है उसको ला के देता हूँ घर और जो ला के देता हूँ वो सब खा जाता है। तब उसके खाने के लिए मेरे पास जो होता है वो मैं कमा कर आता हूँ, मजदूरी करके वो मैं खिलाता हूँ।
खाने में, खिलाने में और सुलाने में और सुबह जाना होता और वो चल नहीं सकती इसलिए उसको उठा के टॉयलेट जाना पड़ता है, लेके खिलाना पड़ता है।
मैं अपनी किडनी भी बेच सकता हूँ मेरे बच्चे के लिए, उसका जब पैसा आएगा उसको बेच कर मैं बच्चे के लिए इलाज करा सकता हूँ।
So, you'll agree that that's a sad movie, and I got this from Mail Online. Some of the things were out of their control, but some of the things were in their control. You know, giving them glasses of Coke and so many bananas and things like that to eat. And it may become a little clearer in the talk later on when we talk about what causes it. So this is what happens. Early death. And there's been a lot of data and experiments done on animal models to demonstrate that your life expectancy is indeed reduced. Anything from 6 to 10 years. In fact, there's some more data emerging that states that it might be up to 14 years of your life that you lose purely because you're obese. Diabetes and hypertension, Chandni Rajani very eloquently presented her talk as the first speaker and mentioned that these are a problem. Dr. Kakad talked about joint problems, Sanjay Popat spoke about oncology, and again in cancer, there are a number of types of cancer like endometrial cancer, breast cancer, pancreatic cancer and some GI cancers that are related to obesity. And last but by no means least, the obstructive sleep apnea, which is something that I deal with, and many of these patients have difficulty sleeping, breathing and having a lot of problems during the sleep, and they present with fragmented sleep and tiredness, and again has a lot of impact, and that's all I'm going to say about sleep apnea, so no more about that. So what was the animal model experiment? They took 3 groups of mice. One group was fed its normal diet. One group was fed 25% less than what they normally have. And the third group was fed 25% more than what they would normally have. And you can see up here the 2 mice. The one is really big and fat, and the other is slightly skinny. And it's the fat mice that dies early. So the ones that were starved, did really well. And this brings into theory about fasting. A lot of people in the Indian community want to fast and all that. And fasting under controlled versions is not a bad thing, and it can enhance life expectancy as well. So why and how does it happen? Well, the obvious features here, and these things that are avoidable, as Chandni mentioned earlier on, excessive food intake and limited exercises. These are the 2 factors that you can all do something about. So essentially what you're doing is your energy intake is greater than your expenditure, and your caloric intake, again, the types of food that you might be consuming are not the right type of food. There are certain things that you don't have any control over. We talked about genetics, so appetite and metabolism is, there are controlling genes that can have an impact on this. There are medical disorders like hypothyroidism, where the thyroid gland is underactive and your metabolism slows down, so you just keep on putting on weight. And the syndromic children, and in fact those 3 children that you saw, I suspect they may have one of the syndromes, and the Prader-Willi syndrome is one of the common ones, where the child has this ferocious appetite and they just cannot stop eating. So there are certain important mediators, and this is very high-tech thing, so I'm not going to talk a lot about, but just to mention a few hormones. So leptin and ghrelin are things that tell you that, whether you're hungry or not, whether you've had enough to eat or not. And some of these things are also related to the manner in which you eat. So your stomach is a sac, and the food and the liquids that you consume will stretch this sac, and there are stretch receptors on there. So one, you have this physical fullness that will tell you that you've had enough. But more importantly, there are hormones that are released, which will then travel through the blood system and tell your organs in the brain, hypothalamus or thalamus, that you've had enough. So people who eat too quickly are not giving enough time for this hormone to go up to your brain and register that you've had enough. It will be the fullness of the stomach that tells you that you've had enough. So eat slowly. That's one of the messages to take home. And other compounds here that will have an impact are insulin and orexin. And these are compounds that will mediate and are the underlying cause if there's a deficiency or a defect that will encourage obesity to occur. How do you fight it? Very simple. Diet and exercise, the 2 things. Sleep deprivation. So again, Chandni mentioned sleep and hypertension, and Kumkaran wanted 6 months of sleep instead of 6 hours of sleep, but that's another matter. So if you are sleep deprived, what happens? You don't get enough sleep, so you're awake for longer periods of time. The fact that you're awake longer periods of time encourages you want to eat more. And again, you can get craving for carbohydrates related to the leptins and the ghrelins and the orexin that I mentioned earlier on. So you get these carb cravings, and your brain wants this glucose, so you will keep on wanting more and more and more. So sleep deprivation is something that we need to fight. In order to fight it, and when you seek help, there are drugs and medication that can help, but it's not for everybody, and you need to see your GP about this. There were, up to about 5 years ago, 3 different drugs that were available. 2 were appetite suppressants. So you take this drug and it suppresses your appetite by acting centrally. They're amphetamines, or amphetamine-like agents. But these have now not been advocated to be used in the UK because of the side effects. So orlistat is the one which interferes with the fat absorption, and that is being advocated at the moment, and it does help people. But if you do use medication, that's not the only thing you should use. You should still think about your diet and exercises. Surgery and things like that can happen. I'll talk a little bit about that, but I just wanted to talk about diet before I go into the other agents. So in the diets, looking at individual dishes, so I got these things from the internet. Saag paneer, 1 portion of saag paneer has nearly 500 calories. And if you're having medu vada, 2 pieces of medu vada has 334 calories. Can you imagine, just 2 pieces of this in saag paneer has gone half your calories of the day completely out the window. So, when you've got a choice of starters like this, and I'm sure Deepak Bhai has got all this lovely food for us downstairs, so please don't let me put you off the food. But these things are not good for you. But steamed food is probably better than fried food. And of course, when you get the main course, and this is a typical Indian thali, one of the things that has been recommended in clinics that are relating to diets is the size of the plate and the portions that you take. So the smaller the plate, the better it is, but you've got a thali like this, completely filled with delights, well, then you're heading for trouble. And desserts are naughty but nice, and if my girls are given the choice, they'll have the one on your left with this fruit, and I'll probably go for one on the right. But things in moderation are always good, okay? Again, I think somebody mentioned that, fruit has got natural sugar, so too much of it can be bad, and that's one of the things that you should bear in mind. Fruit is nice, but again, in small portions. So there are lots of different diets, and people often ask, what diet is the best one? What shall I use? And Atkins diet is a low-carb diet, the South Beach diet, high-fiber, lean protein, low-carbohydrate. There's a high-fat diet. I think all these diets are unnecessary. I think you need to have a common-sense approach. and basically had 3 square meals. So, people that I see in my clinic with sleep apnea, sometimes they come in and say, "Doctor, I don't eat anything in the morning, I don't eat anything at lunchtime. All I have is a nice meal at the end of the day." This is not good. Because your stomach does not receive any food for the first 12 hours of the day, it believes, it thinks, and it acts as though you don't need to metabolize anything. So as soon as you have a binge in the evening, it won't metabolize and you just pile it on. So you do need 3 square meals, but what you've got to think about, and what is quite interesting, and I don't think we think much about this, is the glycemic index, which I'm sure somebody mentioned earlier on. And you have foods of low glycemic index, which means that this food will distribute small amounts of glucose regularly, so your brain is satisfied. So as an example, for a Sunday morning breakfast at my place, I would probably have Dhamecha and jalebi, and Jalpa and Priya will probably have porridge. So having porridge has got a low glycemic index, it keeps them satisfied for a lot longer, whereas I have a huge sugar rush with the jalebis, and then I'll be munching on something else like chirba and chakri, which Chandni showed earlier on. So that's bad. When you look at fats, and people look at fats, and I look at them as the good, the bad, and the ugly. So you've got the polyunsaturated, you've got the monounsaturated, and you've got the saturated fat. The saturated fats are really bad. Okay, so cream cheese and whole fat milk and things like that are really bad. So you need to really be vigilant in what you eat. So if you've done the diet and the exercises and you need medical treatment, still things are not working and your weight is still on the increase, then you certainly need to visit your GP, because they can give you the medication and give you the diet and the exercises. Or you might want to have a referral to the obesity clinic, especially if you've got metabolic syndrome. So for those of you who are not familiar with the metabolic syndrome or the syndrome X, that consists of obesity, hypercholesterolemia, hypertension, and sleep apnea, as well as type 2 diabetes, or 3 out of 4 of those. So if you've got those things, then surgery is going to be extremely useful for you. So surgery is very successful in the selected cases, and in fact, the Royal College of Surgeons are advocating this kind of surgery, although it's very expensive in the long term, because it helps you with the control of your hypertension, your diabetes, and your sleep apnea. They believe it is more cost effective, and it's really sort of in the interest of the health economy to advocate this kind of surgery. So there are lots of different bands available, gastric banding, gastric balloon, that literally limits the capacity of your stomach so you eat less. And you just don't want to eat because you haven't got a big enough stomach. Or you can go for surgery and the different types of surgical procedures. These surgeries are not without problems, so you've got to be very careful what you're letting yourself in for. And if you're selected for this kind of surgery, then it will be quite useful and quite effective, because it does have an impact on all the other risk factors that we mentioned earlier on, especially the hypertension and diabetes. So to conclude, ladies and gentlemen, obesity is on the increase, there's no doubt about it. So you want to avoid the sedentary lifestyle and become more active. Cook sensibly, grill, bake and steam instead of deep frying things. Olive oil is supposed to be very good, so Mediterranean diet has got a lot of olive oil in it, it's very good. You need to eat sensibly, regularly and healthily. You need to exercise. Sleep well, at least 6 hours, without laptops, TV and iPhones. And people often ask me, well, why do they say you can't have laptops and iPhones and TV? What's wrong with them? The kind of light these screens emit into your eyes send messages to your sleep clock. So it confuses your sleep clock. And when the sleep clock is messed up, then your appetite is also messed up, and then obesity comes into being as well. So, do we eat to live, or do we live to eat? That's the question. So McDonald's and these people selling donuts are not going to like me very much, but that's not the right thing to do. And it is indeed a huge burden on the NHS, because recently they've said that if you're obese, then the treatment, especially if you need surgery, anesthesia is dangerous in obese patients. Mobility and all the other things that Dr. Kakad mentioned is also an issue. So it really is a huge burden on the NHS. So please bear that in mind and then don't become obese. Thank you very much for your attention.
Thank you very much. I know there's a few people wanting.
By the way, there'll be CCTV monitoring your lunch downstairs, so you make sure you clean your plates up.
I'm hoping that lunch is a bit healthier than last year, actually, but I know there's a few people who want to try and join you for breakfast on Sunday morning, so you might need to change your breakfast from that as well. Okay, so that kind of concludes all of our talks. We have overrun slightly, so apologies for that. Again, with questions and answers, Professor Kotecha will be upstairs to answer any questions you may have. So I'd like to invite Dinesh Uncle and Vinod Uncle to the stage for some presentations. Thank you.
Thank you. Don't you think all these doctors, Dr. Chandni, Rajani, Dr. Bhik, Kotecha, Sanjay, Dr. Sanjay Popat, and Dr. Jitendra, Kakad have done an amazing job. Don't you think? It is a wonderful round. It is so informative, and I'm literally able to say it's food for thought. And I think that seems to be the key subject that we discussed, and lots of things that we discussed in terms of cancer. Sorry that we couldn't spend the time, because I think in fairness we need to have some more clinics as well now. Before we do that, I do want to say a very, very big thank you to all the doctors, the medical people, and all the volunteers who have kindly helped the clinics upstairs. I think, can we please have a wonderful, wonderful round of applause for all of all our volunteers throughout this 3-floor building, downstairs in the kitchen area where healthy food is being served, I can assure you. And equally here on this floor where the administration is taking place, and on the top where the clinic is based. I think we only could organize this with the blessings of our president of Lohana Community and the executive committee. I'll now please warmly welcome Bhik Thakrar to say a few words on behalf of LCNL. Thank you very much.
Good afternoon, ladies and gentlemen. If I can ask everybody to sit down for literally just another couple of minutes before you go out for either lunch or whatever. We have lunch very, very shortly, but I just literally need a couple of minutes of your time. And also we want to carry on with some of the formalities, which is a very essential part of this function today. Last year when we started this inauguration of this medical event, at that time I said this is going to be an annual event. And I'm very pleased that the support that we are getting from all of you for this kind of event, and I have no doubt in my mind that this will be an annual event for the Lohana community. And I want to thank each and every one of you for your support in coming here today. I can see that we have so many new faces. Normally we get at the religious event and Navratri and events like that, different type of people, but here I have a mixed crowd here, and to see each and every one of you today at our building here is excellent. As Jiteshbhai said, that we are so proud that all these Lohana consultants are with us today. Once again, I would like to thank on behalf of the community that you have supported this event. Jiteshbhai also mentioned that we have so many supports. We have supporters in the clinics upstairs, volunteers. And I want to pick up on a couple of team members. Our IT team, I think they have done a fantastic good job. If not, they would switch me off, so I have to be very, very nice to them. The other couple of people that I want to thank personally is our photographers here. Photographers, they're not Lohana members, they kindly come and support us every time we ask them. So can we just give them a round of applause? ઘણી વખત એમ થાય કે આ ડોક્ટરો બધા આવે છે કે તમને જમવાનાની ના પાડે છે, જલેબીની ના પાડે છે, સમોસાની ના પાડે છે, પાનની ના પાડે છે, ડ્રિંક્સની ના. ભીખુભાઈ લાઈફ કેના માટે છે પછી આ બધું બંધ કરી નાખશો તો આપણે કરશું શું, you know? Absolutely. So, but I think they gave us some fantastic advice, talks and so on, and long may it continue. Your support to the community is very much appreciated. What we want to do within the community is work together. It is not just about us and you kind of thing. It is togetherness. We want to enhance the standing of our community, and I think over the last few years we have done extremely well. And one of the reasons is we've now got our own building here at Dhamecha Lohana Centre. And because of that, we can organize some fantastic programs of this type. So I really don't want to take up a lot of time, but I want to just mention 2 or 3 programs coming up soon. On 18th of March, not too long to go, our senior ladies are celebrating their 5 years of the community in the service to the community. So if you can support them. And the program after that is Jiteshbhai Gadhia was here. I think Dinesh, quite rightly said one of our youngest Lord, and we are proud of that fact here at the Lohana community, and we are felicitating Jiteshbhai on 19th. જે મેમ્બરને જોડાવવું હોય તો they have to get the passes. In fact, our membership secretary is sitting out there in the front. They have to register for the passes. Do come and join us, like you always support us. And the very last program that we have is AGM on 2nd of April, and I'd like to see each and every one of you at the AGM as well. Thank you very much for your support.
Thank you very much. We know it is customary, of course, that when doctors with such qualities come and talk to us and share their knowledge, experience, and information with us, we do acknowledge them. So what we want to do is, with your permission, what we will do is we'll present 4 plaques to the 4 doctors, and of course, ladies first. So if I can request our Jatenia, please, our Secretary of Law in North London, to present the first of these plaques to Chandni, Rajani on behalf of the medical camp and the London community. Yeah. Thank you very much. The second plaque, we want to request Deepakbhai Jatania, please, to present this to. Shall we get you to present to our your relation, Dr. Bhik Kotecha? You're happy about that? Good. Big sir, please come forward. Thank you very much. Thank you. If I can then request Thakrar, our President of Lord Committee in North London, to present to Dr. Jitendra Kakad a plaque on behalf of Medical Camp and Lord Jiteshbhai Gadhia. Thank you very much. Finally, of course, I think I'm going to grab this privilege myself, if that's okay, and present this plaque on behalf of our committee and Dr. Sanjay. Thank you.
Can I finally thank Jiteshbhai Thakrar and his team for doing a fantastic job on behalf of the community. Thank you very much. You can see we have so many people, and the program has gone excellent today, and I think we're almost ready for lunch.
Yeah, I know we're all getting hungry after that talk not to eat. We are ready for lunch. Sukesh just wants to make an announcement, but other than that, light lunch is being served downstairs, and the clinics are now open, please. Thank you. Sukesh?
I hope everybody enjoyed themselves today and found it useful. As Jiteshbhai said, we have clinics upstairs which will be running till 3 o'clock. We have very, very healthy food downstairs. Sorry, no jalebis. And also we have a nutritionist who's going to talk to us here. So a group of say 10-15 people who want to listen to the nutritionist. She will be doing a PowerPoint presentation and answering your questions. So whoever wants to stay to listen to the nutritionist, please do stay downstairs. Thank you.
Not forgetting to thank our Masters of Ceremonies today, Ami and Sanjay and Sukesh. Thank you.
Yeah. Okay, so I'm going to start the talk. My name is Thakrar. I'm a pharmacist, homeopath and a nutritionist. And I run a clinic in Ealing, and I also do many talks, and I write articles. And what I do mainly is to look at lifestyle and how to have a holistic lifestyle. Today there was a lot of talk with all the consultants, and one of the main topics that they all mentioned was to do with nutrition, food. Food is really, really what makes your health, and it's something that you are in, nutrition is something that you're in control with.
All right.
Can you see me now?
Yeah, that's
okay, good.
Thank you.
So nutrition is something that you can be in control of, and I'm going to just give you some ideas on how to optimize your nutrition. Before I start, we giving out little note. My colleague Ashla is just giving that out. If you can on that write and make a commitment. Once you've listened to everybody talk today, and now what you need to do is make a commitment to yourself to make one change. So what is it that you're going to do? You need to write that down. You can do it now, you can do it after I've done my talk. But make a commitment, make a decision that this is the change that I'm going to make in my lifestyle, in my nutrition. So, I have, for more information about today's talk and any other talks that I do, any articles, please do look at my website, which is ninathakrar.com. Nutrition and obesity. There was a talk on obesity, and obviously in that talk, nutrition is the most important balance that we need to achieve. Nutrition can influence many things. Energy, weight loss or weight gain, hormones and moods, sleep, learning and concentration, and immunity. These are all the factors that can be influenced by nutrition. This plate is a blueprint of what we should have on our meals, and that was covered shortly, but I'm just going to go into a bit more detail about what should be on your plate. So you can see the larger portion is the vegetables, the next is your protein, then smaller portions are your carbohydrates and your fats. And of course, not to forget water. So the first one, which is a very important part of our nutrition, is protein. Why is protein important? Protein helps to improve our metabolism. It boosts our immune system. And it also helps to repair muscles and cells. The daily intake of protein. Daily intake of protein is 50 grams of protein per day. Sorry, I'm just going to move this. 50. Can you still see me? Sorry, it's just I couldn't see the screen otherwise. That's fine.
So 50 grams per day?
Yes, per day. One handful, yeah? So I'm just going to go through some of the details of that. So the highest vegetarian sources of protein. Kala chana, which is very good for diabetics because it helps with your blood sugar balance. Red lentils, sprouted grains, which we had at lunchtime today. If anybody doesn't know how to make sprouted grains, please do come and see me afterwards, and I can explain to you in a bit more detail. Yeah. Okay. I'll be having a clinic upstairs, so if you've got any questions or you want to see me, please do. Nuts. And nuts should be really a variety of foods in there. So we should have a mixture of nuts and a mixture of seeds. Yes? Yeah, so raw nuts are the best. You can have roasted nuts. The ones that we don't want to have is the tarela jugu and the tarela kaju. We don't want to have those. Because we eat those and say, oh, I've had my portion of nuts today. But no, that's a big no-no. And also, please do include seeds in your, now seeds can be on your porridge. It can go on your salad. It can even go when you're having your pasta or your dal bhat, and you can just put a little bit of seeds on there. But seeds contain essential fats. So these are good fats because we call them essential fats. So they're good fats which are very beneficial for our joints, for our brain function, for our heart, many different organs of the body. Other sources of protein from vegetables. Examples are the lima beans, edamame beans. We heard of that? Edamame beans? Yeah. Sweet corn, broccoli, asparagus, cauliflower, aubergine, mange tout, kale, which is a new type of spinach that people are beginning to now eat, and of course the normal spinach that we have, and watercress. Vegetables are good sources of protein, but one of the issues we have is that we overcook our vegetables. So if there's a little bit of crunch in our vegetables, it's better than overcooking our vegetables. So when you're making your shak next time, please make sure that you don't overcook. Carbohydrates. Yes, important in our diet for energy. But carbohydrates can also give us weight gain. And of course there was a lot of talk today about obesity and weight gain. So I will cover a little bit on the nutrition side. Carbohydrates, two types, simple and complex. Anyone heard about simple, complex carbohydrates? Yeah? Okay, so I'm going to go through that a little bit to understand what that is, yeah? With carbohydrates, you need to have, for men it's 56 grams, around 56 grams, and for women 46 grams. White rice, if we're going to eat white rice, it should be about the size of a tennis ball. Potatoes would be a medium potato, but I often recommend trying not to have potatoes as they're very starchy in the diet. If you want to have some form of starchy carbohydrate, have a sweet potato, have a small sweet potato. Bread, again, you can weigh the bread that you're eating to make sure your grams of carbohydrates, because remember this is carbohydrates in a day. So if we have like 3 slices of toast, and then we're going to have a little bit of bread in the evening, because we're going to have it with our shak, or we're going to have rotli with our shak as well. You have to think, how much carbohydrate am I eating in a day? It's crucial that you actually are mindful about what you are eating. So, carbohydrates, how do we switch to more complex carbohydrates? So the simple carbohydrates would be white flour, white rice. We want to make the change and we want to go for more complex carbohydrates which are broken down slowly in the day, and also the energy from those carbohydrates are released slowly. So, and they will help to maintain our blood sugar through the day. So we want to eat more complex carbohydrates. So white rice, instead of having white rice, have brown rice. And have quinoa. Anyone heard about quinoa? Yeah. So you can see on this picture, you can see the quinoa with some vegetables in there. So you can make a biryani style with vegetables, and you can use quinoa. Or you can add a bit of brown rice and quinoa. You can make khichdi with quinoa and also some brown rice and a mixture of white rice instead of just having plain white rice. You can use, for rotli, you can use the mixed grain, you can use whole grain, you can use spelt flour for rotli rather than having the white wheat flour. You can also have rotla instead of the rotli, which is even better. More fiber, more complex carbohydrates. Next one is about fats. So there is a big taboo about fat-free diets. Everything is fat-free. You'll see the yogurts with the sugar-free, fat-free. you'll be seeing other foods, which says, oh, I'm on a fat-free diet, I can't have fat. We need small amounts of fats in our diet, but these are good fats. We want to try to have good fats in our diet because we need fats for our brain function, for our joints, for our heart health. We need some good fats. These are called essential fats. It's the fats which are the bad fats, which I'll go into more detail, which leads to obesity. So these would be more the fried foods. Advantages of fats: rich source of energy. You also get soluble vitamins. It helps to absorb soluble vitamins. Maintain regular heart health. Important for cell membranes, so for our memory, the actual cells have around them fats which actually help for it to stabilize and for absorption. Anti-inflammatory. So often you're heard, isn't it, about omega-3s, having it for our heart health. So this is an essential fat. It's still a fat, but it's essential fat. It can also help regulate cholesterol. Disadvantages of fats. So these are the wrong kinds of fats, which will give heart disease, leads to weight gain, diabetes, blood pressure, which is everything we discussed today. So the fats, you have the saturated fats. So the saturated fats, they are good in moderation, but if you have too much of those, then they will cause diabetes and cholesterol. Monosaturated fats, these would be more your olive oils, rapeseed oils that we've seen. They help, they can be very useful, in, again, small amounts, but they can help with lowering blood cholesterol. There's polysaturated fats, these are your sunflower, soya, sesame, corn oils. They also help with lowering blood cholesterol, again small amounts. And then we have the trans fats. So the trans fats are your margarines and vegetable shortenings. Trans fats are fats where the molecules have been altered. So when a margarine is made, it's actually been altered so that it's stable and it's got that soft like, as you know, if you put butter in the fridge, the butter becomes hard, but you leave it outside, it's soft, yeah? You put margarine in the fridge, it's still soft because the molecules have been altered. And also, it's often colorings are added to margarines. So margarines are not always necessarily the best fat that we should have.
Sorry,
Again, Benecol is a type of margarine, but it does have some ingredients in there which help to lower blood pressure. So obviously, that's what it's being marketed for, but I wouldn't necessarily say that that's the best type of fat.
So shall we use margarine or not?
No.
So no butter, no margarine.
No, because the fats are, because the molecules have been altered, so it's artificially made. In simple terms.
If we don't use butter,
so butter in small amounts you can have.
I see.
Olive oil is very good. So if you're going to have bread, often it's quite good to have it with olive oil, coconut oil. Some of those which I'm just going to go through, the friendly fats. So these are your friendly fats. So the friendly fats are the omega-3 rich oils, butter in moderation, rapeseed oil for salads. Okay, olive oil, best for salads, but not for cooking. And I'll explain that because you may be coming across olive oil using for cooking. Exactly, yeah. Virgin coconut oil, a really, really good essential fat. And then you can also get the spray oils. Now, those are quite useful because sometimes we put too much fat. We're making our vagar or we're putting something on our salad and we use too much oil. We end up putting a little bit too much because then that tarka that you do will be even better. But actually you're just burning oil, really. You're just burning the oil. And we also think that, you know, when we're doing the vagar and we're using the oil and then it starts to get a little bit of cloudy, then you're thinking, oh yeah, that's it. You get a bit of fumes coming and you say, yeah, now it's hot. But actually, it's damaged. No good for us. So, today, everybody talked about this. Yeah, we enjoyed fried foods. We all enjoy fried food. But some tips to understand, yeah? Deep fried foods contain harmful products, yeah? Because the fat has actually been destroyed. The molecules have been destroyed, and that destroyed, altered molecules is going into our body. Our body doesn't know what to do with it. So it starts storing it in places, it's trying to hide it. And it will start hiding in places which we don't want. Okay? So if you like samosas, bake them. You know, use the spray can, spray a little bit of oil on it, and put them in the oven and have it from the oven. It's still very tasty. You still get all your vegetables in them. Instead of frying, always try to bake wherever you can. Another question that I get asked so often, and it is on my blog, an article that I've written, is about once I've fried the food, can I use that oil again? Can we? Can we use that oil again? No. Just one more time? No. Or can we put it in our rotli no more? No. Do we? No. No, we can't. Because once that oil is heated, it's destroyed. The benefits are destroyed. So we're just reusing it and we're actually causing harm to ourselves. So don't use that, okay? Also, with using sunflower oil, we're used to using sunflower oil, but actually it's a polysaturated vegetable oil, and actually it doesn't have a lot of benefits because it's not very stable in heat conditions, in high temperatures. So try not to use the sunflower, okay? You can add a bit of water to the oil. Once when you're doing your vagar or anything, add a bit of water to add, to get a little bit of more, you need a little bit of oil mixture to actually put your vegetables in, yeah? Sweet tooth, sugar. How much sugar should we have? So when you're eating a dessert, always make sure that you try to have more of the natural sugars. So try to have, if you really feel like, yes, I think, we're going to have a dessert today, then try to have with nuts, with dried fruit, rather than having sweets, which is highly sugar, and then it will have some form of evaporated milk in there. Sometimes it's fried, Remember, we enjoy the taste at that time, but we're paying for it later on in our life. So, eat mindfully. Think about what you're eating. Okay. Then vegetables, yeah? So how much vegetables? 2 types, even in the vegetables. We've got starchy vegetables and we have non-starch vegetables. So starchy vegetables has more carbohydrates. When we have a jacket potato, often you'll have a jacket potato at lunchtime and then afterwards you feel tired, feel a bit sleepy, feel a bit heavy, because it's very starchy food. So it's hard to digest starchy food. It takes time for our body. And also, when we eat starchy food, it has high calories, a lot of starch in there which actually get your blood sugar to go up, and then you feel that sleepy feeling, that tiredness, because the blood sugar will go up and then it will go down. Okay, so you get spikes of blood sugar. So what you want to try to have is small amounts of the starchy vegetables, and try to have more than non-starch vegetables, which there are examples here, and there's plenty of variety of vegetables. As we all know, we can make lots of different types of shaks in a healthy way. Best way to eat your vegetables. Raw is the best way, but often if we have a sluggish digestion system, sometimes it's difficult to digest raw food, then have it steamed. So you can even steam the vegetables and then make a shark. Then make a quick stir fry type of a shark, yeah, with your spices, so it's still tasty, but you're getting all the nutrients. You can bake and use a spray can and just put a little bit of oil and put it in the oven, and you can bake the vegetables. You can do a stir fry. You can grill the vegetables, which is also very healthy. And the last one is the boiling. So it's the boiling that often we lose a lot of the nutrition from there. So try to use the ones above first. Examples of portion sizes, just these are for fruits and vegetables. So 3 tablespoons of peas, 3 tablespoons of kidney beans, 3 tablespoons of sweet corn, kiwi fruit, cherry tomatoes, asparagus, plums, cauliflower, so plenty of choice. But make sure you know your portion sizes. So when we're eating fruit, keep the portions low. Other examples of fruit. When we're having fruit, and there was a lot of discussion today about eating fruit, and I've had people come up to me today and say, when do I eat my fruit? What time? Fruit is better to have earlier in the day. It still contains sugar. So for us to digest fruit, it's very good if you can eat fruit before your meal. When we eat fruit after our meals, your stomach is already trying to digest the food that you've eaten. Fruit, when you eat it after a meal, it requires different types of enzymes to break down that food. And fruit can start fermenting because it's sitting there on top of the food that we've eaten. That fermentation will cause us to have bloating. It can also cause us to have a rise in blood sugar. So I know that we're used to having our meal in the evening because that's our main meal quite often. And then after that we sit together, social as well, and we have a big plate of fruit. But that big plate of fruit, firstly, we can overeat because we don't need that fruit afterwards because we've had a meal. Do we need the fruit? No, it's a social thing that we're doing. There's a lot of sugar in that. What does the sugar do? You know, in the evening, do we then go to the gym? Do we go for a run? Do we do anything in the evening? No, we sit and we go to bed. So what happens to that sugar that we've eaten? Already the stomach is trying to digest this meal that we've had, and then on top of that we add fruit to it. So fruit should be earlier in the day. So if you're going to have fruit, have that before your meal. Have a small portion of fruit, but again, small portion, not a big plate. I've had so many people come to me and say, well, you know, we cut up a big plate of fruit in the evening. That's too much. Small portions through the day, earlier in the day. So portion guidelines. So I brought, just to show you on portions, about just simple vatkis that I brought, yeah, just to show you sort of what portions, yeah. So what is the most important out of all the proteins, carbohydrates? What do you think is the most important portion that we should be concentrating on? Proteins, yeah. So proteins and vegetables, yeah, Ravinda. So when we're gonna have protein, we want to go for the big vatkis, yeah. So we want to have this and a couple of these for the vegetables. So we want to have one of these, and so when you get these vatkis, you know, buy some, and just it helps you to think about what you're eating and think, have I had my dal or my chana, whatever, have I had one of these or maybe even 2, it's fine, yeah? Or have I had vegetables, 2 of these vegetables you can have, you can put salad and have this, and then the smaller one will be for the rice, so I would even go for half of this. So even half a portion, so we're looking at a tennis ball, really small portion of the rice. And do we need rice and rotli in the evening or in the meal? Do we really need it? No, we don't. choose one or the other. Yeah, choose one or the other. If you're going to have roti, maybe have that at lunchtime and then have a small portion of rice in the evening. But unless we're very active and we think that we're going to use up all that carbohydrates that we're eating, we have to be very active. To lose weight, we need to be active, but more important is what we put inside us. So this is the indulgence, isn't it? This is the thali, the dream thali that we all would love to eat and stay slim and fit and healthy. This just gives you an example of some of the portion sizes that I've already discussed. This is also other types of protein that we can have. So we've got the quinoa, which I've mentioned. Then another one is chia seeds. So the chia seeds, these are some of the superfoods that as they're called now. Chia seeds, you can make a dessert with chia seeds. Chia seeds contains omega-3 fatty acids. It contains protein and fiber. And you can make a dessert with that. If you need any more information, please do come and see me afterwards. You can make pancakes with buckwheat flour you can buy, and you can make pancakes with those. Today's meal, I'm just going to go through a little bit of the healthy meal we had, healthy lunch we had, yeah? So that we had idli sambar. So anyone know what the idli sambar might have contained? Is it carbohydrates? Is it protein? What? How many say carbohydrates only? Yeah. Protein and carbohydrates? Yes. Yeah, absolutely, yeah. Because the idli contains rice, but remember it contains earth. Yeah, so, and one idli is around 65 to 70 calories, okay, which is not bad when you're looking at it overall. Because actually we could consume one idli and it's quite filling. I had one idli, I was like, great, it's perfect. And the dal will give us lots of protein, plus we have the vegetables in there. So we're getting the vegetables. So it's a complete meal. All we need is the salad. And we had a superfood salad today as well, didn't we? Yeah? And we had the vegetable biryani. We don't need to have that, but we can have in small portion. And there was lots of sprouts in there, which I mentioned as well. Another benefit of the idli is that it's a fermented food. When it's naturally fermented, the fermentation process helps to absorb the nutrients that we're eating from food. So the fermentation will actually help all the B vitamins, the C vitamins, whatever the vitamins are, it will help because that will give us, and it will reduce bloating that we often get with our stomachs. So digestion in simple terms. Make sure that you chew your food very slowly. Take time over eating. Avoid drinking while you're eating because that dilutes the food that we're eating and it will have an impact on the enzymes that are released when we're digesting the food. And eat early in the evening. Try to eat early so that your stomach has plenty of time to digest the food. And add live food to your diet. One of them is a supplement. You can buy it in a supplement or you can buy it as a drink. It's called kefir, which has got a lot of good bacteria in there.